Okay, part two. So in part one, the last video, we mainly did anatomy and physiology. And here we're just going to dive right into pathology. And again, it really helps if you have this nice foundation to build on and interpret things through. All right, so what we're going to talk about: embryological defects, brain lesions, cranial nerve lesions, spinal cord lesions, strokes, hematomas, intracranial pressure, and hydrocephalus, tumors, neurocutaneous disorders, headaches, seizures, neurodegenerative disorders, demyelinating disorders, vision and fundoscopic examination, hearing and balance, and then we never really get to pharma, so you guys are on your own for that. All right, embryogenic defects. So there's neural tube defects. If you have issue at the caudal end, this is going to be spina bifida at the posterior. At the superior rostral end, you're going to have anencephaly, Dandy Walker, Chiari malformation, hollow prosencephaly, lissencephaly, and syringomelia, which we actually talk about, I think, somewhere over there. All right, so folic acid. Folic acid is really important. So B9 and B12 are going to be tremendously important for methylating things. So in particular, folic acid B9 runs out really quickly. You have a lot more stores of B12 than for B9. And there's a lot of reasons that B9 is more important than B12, but pregnant women need to take a lot of folic acid because you need a lot of methylation to convert uracil to thymine. And it turns out there's a lot of cell division going on when you're baking a baby. So folic acid, very important. Medications that can interfere with folic acid will be valproic acid, and then methotrexate is a competitive inhibitor. In fact, this is so catastrophic that they actually use this to induce an abortion and for things like ectopic pregnancies. So yeah, you get tons of birth defects if you have folic acid deficiency. So there's two different routes we can go. We can generate a SAM with the B9 and B12. This can methylate a lot of downstream things. One really important thing is a phospholipid, ethanolamine to choline, which we'll see in a second. But also 5,10 tetrahydrofolate is going to generate thymine. The SAM is important. You don't really have to understand most of this, but ethanolamine to choline. And I just remember the CH for the methyls. Here we're adding these methyls. This is an important component of myelin, and this is why you would get neural tube defects, is because there's something wrong with the myelin production, and you get buildup of metabolic intermediates and whatnot. But that's at least how I remember that this is a neural tube issue. AFP is going to be a marker for a lot of these things. So you have less AFP, interestingly, in Down syndrome, more in spina bifida, not in occulta, which is sort of the most benign of the spina bifidas, and then anencephaly, you're going to have extra as well. Anencephaly, so we're having a hard time forming like the superior aspect of the neural tube. So really, they just don't have a top half of their head. And so for that reason, they're going to have trouble swallowing. And if you can't swallow, the baby's generating more urine than it's able to swallow. This can result in polyhydramniosis for the mother. This is typically not compatible with life for too long. So spina bifida, so this is going to be our normal. Here we have occulta, so maybe we have a lamina defect. There can be other issues with the vertebral arch, but it's just something's wrong with the vertebral the vertebra, and the myelin is where it's supposed to be. The meninges are where they're supposed to be, and you sometimes have a little tuft of hair in the lumbar region or a little skin dimple. Moving on then to the next first one, which is meningocele. And if you think about this, the meninges. So the meninges here, so again, we have this little crack in the lamina where the meninges can poke through, and we see the same thing over here. But the actual spinal cord itself is maintained well within the vertebral column. And then this last one is the worst one. This is myelomeningocele. And this is the meninges are out, and the myelin, which is to say the spinal cord itself, is also out. So both of these are out. This is going to be associated with a Chiari type 2 malformation. Speaking of which, Chiari malformation. So type 1 is associated with syringomyelia, which is we're going to find this large sort of benign growth in the in the thoracic region, maybe in the cervical region. And this one's less severe. This is going to probably manifest in adulthood. And what happens is you're going to have this downward displacement of the cerebellar tonsils, which can cause a non-commuting hydrocephalus. But again, this is the less severe one. I would mostly know this is associated with syringomyelia. More severe one is Chiari type 2. So this one you're going to have more severe displacement and herniation. So now it's not just the tonsils that are going down, but it's actually the vermis as well. So here we see the tonsils, and here we see the tonsils and the vermis. So these are going to both be pushed downwards, which is partly what's causing the obstruction of this fourth ventricle here, hence the non-communicating hydrocephalus. And we mentioned that this is associated with myelomeningocele, this type 2 Chiari malformation. Syringomyelia. So this is where we're going to have this, this large benign growth, this collection of cerebrospinal fluid that I don't know if it's coagulating or precipitating somehow, but it really just gets stuck. It gets lodged. And it is usually going to be in the thoracic regions. And we're going to see it pop up sort of right here, right at the anterior white commissure. So the spinothalamic tract, we know, comes in from the dorsal side of the spinal column, and then it crosses over at the level of the spinal cord. So that's where it decussates, and then it moves up. Remember that the other two, the corticospinal tract and the dorsal columns, they're going to decussate at the lower medulla. So if we're decussating here and we have this, this syringomyelia, this CS fluid-like precipitate, we could have a growth here, and we could actually damage the cords as they're crossing. If it grows even larger, it could actually affect the lateral horns too, because remember, we're in the thoracic region, and this is where the lateral horns are, and so we could have a Horner syndrome. There is an exception, not so much an exception, but keep in mind that we have Lissauer's tract, so that actually the spinothalamic tract might run up one or two levels sort of around here before it then decussates across. So let's say you have a syringomyelia, from the T10 to T4. Well, it actually might only affect the spinothalamic tracts for T8 to T4 because of this Lissauer tract. And it's because it's, again, the thoracic region, and spinothalamic is going to be pain and temperature. It's often said to be a cape-like distribution. The Dandy Walker malformation now is, so the Chiari is a downward displacement of the vermis. This is now an agenesis of the vermis, which again is this central part of the cerebellum. And if we don't have the vermis, well, then the fourth ventricle, the fluid is just going to fill that empty space. And so you're going to have an enlarged posterior fossa, and here we can see all of this cerebrospinal fluid, which can cause non-communicating hydrocephalus. Hollow prosencephaly. So hollow just means to be made whole, and it is a little bit morbid, but we have these two separate ventricles. This is normal, right? That's what we want. Well, to be made whole, the idea is that they're fusing together, which is bad. So you get this large monoventricle, and this is because the forebrain is not separating the two hemispheres. This is a proper, brain, the telencephalon. And again, we have this fusion. We have a left hemisphere and a right hemisphere. Well, you don't here. Found this, so this is associated with Patau syndrome, trisomy 13, and you get lots of facial, defects and cleft palates and whatnot, and cyclopia. Horrible in humans. Baby goats, a little cute, I'll be honest. They eat this type of flower somewhere in, I don't know, let's say Colorado, and it has an inhibitor for Sonic the Hedgehog signaling, which is necessary for this differentiation. And so they will develop hollow prosencephaly, and I don't know, I just think they're adorable. Lysencephaly, you can just think of these two S's as wrinkles, and that's how you know what this is targeting. So this is a person with wrinkles. This is a person with Botox. This is a normal brain with wrinkles. This is an abnormal lysencephalic brain with no wrinkles, right? So we really have not much of a distinction between the gyri and the sulci, and we need these natural invaginations. So if you don't have these here, bad things happen. Phineas Gage was a railroad foreman who an explosion catapulted this large iron rod through his skull and his frontal lobe, and somehow he lived miraculously. And people then we now know the frontal lobe has a lot to do with behavior and emotion and complex thought. They didn't really know this back then, but people said that he had these dramatic behavioral and intellectual changes. It's probably the case that was exaggerated, but what is true is he certainly sparked a intellectual revolution in neuroscience, where this debate on cerebral localization, kind of reverse engineering the brain came about. So this is a big breakthrough for a lot of psychologists and neuroscientists of the day. Anywho, we're talking about lesions. So don't ever think of lesion anytime there's damage, whether it's, you get smacked in the head, or there's a stroke, or, you have multiple sclerosis and you demyelinate a region, or there's a tumor, etc. Anytime you have damage, we're just thinking, again, reverse genetics, right? Gene X, we want to know what it does. We do a knockout. Your ears get really big. Oh, okay, Gene X had something to do with keeping your ears normal. We're doing the same thing for all of the regions of the brain, and then the spinal cord and the nerves and whatnot. Frontal lobe, so like Phineas Gage, we know that concentration is going to be suspect. Judgment, if it's the precentral gyrus and the posterior aspect of the frontal lobe, the primary motor cortex, if it's central is going to be if it's an ACA stroke. Lateral, it's going to be if it's an MCA stroke. Lateral is the most common. You're going to have arm and face contralateral weakness. But the face, we're also talking about the muscles for the voice box. So you might have trouble speaking, and you might have trouble swallowing. But dysarthria is difficulty getting the words out, like from a mechanical perspective. Primitive reflexes also might emerge. So things like the Babinski reflex, where you point your toes up. It's weird. Your body always wants to point the toes up when that reflex is stimulated, but it's your frontal lobe, for whatever reason, that inhibits this. It does the same thing we're going to see in a second with the red nucleus. So it's constantly telling the body, no, don't do that, don't do that, don't do that. Well, if you take out the frontal lobe, like you get a giant rod through the head, you don't have that voice of reason, and so a lot of these primitive reflexes will reemerge. So dysarthria is because we don't have the muscles to generate speech, but dysphagia is that we don't have like the certain intellectual capacity to generate speech. So Broca's area in the frontal lobe, the language is almost always on the left side. This is going to be broken speech. Actually, this is not fluent aphasia. So this is just broken speech. The person knows what they want to say, but they just can't get out the right words. There's gonna be a lot of pausing, a lot of stuttering, a lot of Wernicke's aphasia is now going to be like a word salad. So they will just talk, ow now, brown cow, there you go, big man, hello, there you go, good kitty. And it's just, they're saying a lot of things, and I'm kind of exaggerating, right? There might be some rhyme or reason, but for the most part, it's going to be nonsensical, but it comes out very fluently. So this is the fluent aphasia. Broca's, Wernicke's, definitely know what those are with respect to the Sylvian lateral fissure and the central fissure. So parietal lobe lesions. So dominant, if you're right-handed, you probably have left dominant brain. If you're left-handed, you might have right dominant brain. Again, for most people, the language is nevertheless going to be on the left side. So for the dominant part of your brain, if there's a lesion in the parietal lobe, you'll get Gerstmann syndrome. Agraphia, so you're going to have difficulty writing. Acalculia, you're going to have difficult doing mathematical equations. Agnosia, you just can't recognize things. You might not be able to recognize your own hands. And left-right disorientation, this is exactly what it sounds like. You have a hard time differentiating the left side of your body from the right side of your body. If it's the non-dominant lesion, just agnosia of the contralateral side of the world. For the post-central gyrus, we have a lot of the density of sensory neurons receiving input from the DCML and the spinothalamic tract. This is going to have the same homunculus sort of geography, where central ACA is going to be for legs, and then the MCA is going to be for the arms and face. Occipital lobe lesion, so this is pretty much just vision. But the vision, you're still receiving light, right? It still goes through your optic nerve, optic chiasm, optic tract, medial lateral geniculate nucleus, superior colliculi, then the radiations. But when it gets to the optical lobe, you don't really know how to process it so much. So this is an artistic simulation of what it looks like for someone who's had a stroke in this region. Same here. You can recognize a lot of these things, but your brain's kind of confused. It doesn't actually know exactly what it's looking at, right? We might say like, okay, this is kind of a jacket and that's kind of a hat, but I don't understand where it is in context. And this is like a calendar, but it looks like Chinese characters. And you really just can't make heads or tails of it. And similarly, so these people are going to have face blindness, difficulty recognizing objects. They might have illusions or hallucinations. And for the cortical blindness, just to emphasize the macular sparing, So it depends what the issue is with the occipital lobe, but if it's likely a stroke in like the PCA or MCA, so both of those are actually going to supply the occipital lobe, PCA a little bit more, but they both will equally supply the part of the occipital lobe that has to do with the macular central vision. So if you have a stroke, it is likely that this will be spared. So you have macular sparing here. Your light reflex are going to be normal. These are reflexes. They don't really have much to do with your occipital lobe. This is just like the superior colliculi and whatnot. All right, temporal lobe. So temporal lobe, you might have, this is where hearing is processed. Tempo is in feet as in hearing. Wernicke's aphasia. Again, there might be a little bit of overlap. Broca's and Wernicke's and the arcuate fasciculus are kind of close by one another. But again, this is going to be fluent aphasia. If you have damage to your amygdala, you might get Kluver-Bucy syndrome, where you have hypersexuality and hyperality. And I just thought of this picture right here. This can be caused by, among other things, herpes simplex encephalitis, HSV. Hippocampus takes like short-term, like new memories and converts them into long-term memories. So if we don't have this, we're going to have anterograde amnesia. The mammillary body is something that's damaged if you're an alcoholic. If you're an alcoholic, you have a vitamin 1 thiamine deficiency, and you might get Wernicke-Korsakoff. Wernicke is talking about the damage to the vestibulocerebellum, so you're going to get ataxia, and you're going to have like nystagmus and certain vision issues. But Korsakoff, I always think of like off your rocker. People are going to confabulate. They're going to make things up. Why are they making things up? Because they have both anterograde and retrograde memory, and the brain is sort of striving for some sort of coherence, right? They might get up, go to the other room because they want a soda, but they get to the other room, they don't remember why they're there, right? They don't remember wanting a soda. And you ask, hey, why are you here? They'll make up some ridiculous story so that they seem rational. I think this is both conscious and subconscious, like it is a defense mechanism or something. But so I think of people being off their rocker. Memory loss leads to confabulation. Cerebellar lesions: don't eat greasy foods. Don't eat greasy foods. These two together are sometimes called the interposed nuclei. So if we have a lateral lesion, whether in the posterior lobe or on the anterior lobe, this is the cerebrocerebellum. So if I want to kick I'm lining up to do like a penalty kick, in soccer or something, and I want to plan exactly how to kick the ball, how to strike it. This is going to be the cerebrocerebellum that's kind of fine-tuning these movements. And again, this is the dentate nucleus because this is the most lateral one. If I have a medial lesion in the cerebellum, it's going to be the interposed nuclei, which is again either the globose or the emboliform, or it can be the the fastigial nucleus. This can damage the vestibulocerebellum or the spinocerebellum. So here we have the spinocerebellum. Spinocerebellum is receiving inputs from proprioceptive, like dorsal column. And so we might get something like truncal ataxia. We might get like a wide base gait. And if we damage, also kind of centrally, but maybe not the floccular nodular lobe is kind of a weird place. But if you damage the floccular nodular lobe, this is also receiving inputs having to do with balance, having to do with people can develop vertigo if either of these are damage is occurring here. But the floccular nodular lobe receives inputs from the eyes and from the vestibular system. So you can get nystagmus, and you can get a truncal ataxia as well. Basal ganglia lesions. So the basal ganglia, a bunch of different parts, went over this in the last video, but the subthalamic nucleus is part of the indirect inhibitory pathway. It is specifically trained to activate that which is inhibiting the thalamus. The thalamus is a yes man trying to activate the cortex, whatever it wants to do. And so if you take out this part of the indirect pathway, well, then you have less inhibiting, which means you're going to have more movement. That's why this is a hyperkinetic disorder. We call this hemiballism, because you're kind of like going ballistic. People's arms are just kind of, shaking uncontrollably. You can kind of see this right there. The substantia nigra. Now, this plays a central role in both the direct and indirect pathway. But initially on, that's still true what I said, but I was thinking about Huntington's. All right, substantia nigra. So we have the reticulata. Reticulata is going to be for retarding movement. That works with the GPI to inhibit the thalamus. But then we have the substantia nigra compacta, which is what has the dopamine. So this is going to pour dopamine, D1 receptors for the direct pathway, D2 receptors for the indirect pathway. So in other words, it's amplifying the direct pathway and it's inhibiting the indirect pathway. Inhibiting the inhibitory pathway just means activation. Amplifying the direct pathway just means activation. So it is pro-movement, the substantia nigra compacta. If you have Parkinson's, there's damage here, and so you're going to get hypokinetic or akinetic movements. We see this little this shuffling gait, right, having a hard time moving. The striatum is what I was referencing a second ago. This plays a central role in both the direct and indirect pathway, as is the substantia nigra, but this is a little bit more central. The striatum in Huntington's is actually the indirect pathway is what's affected first before the direct pathway. So if this is the case, you don't have the indirect pathway and you're going to get these hyperkinetic movements, similar to hemibilism. Except this is typically unilateral and the other ones are bilateral. Lesions of the dorsal midbrain. So Paranod syndrome is something that will develop if you get a lesion here. So it can be caused by, so we have the pineal gland. If you get a tumor of the pineal gland, this can press on it. Or if you have just hydrocephalus, typically non-commuting hydrocephalus, this can compress on it as well. A couple things to be damaged. The Edinger-Westphal nucleus is important for the pupillary light reflex, where if I shine a flashlight in your eyes, it's going to cause both your direct and consensual pupillary constriction. So you won't be able to constrict your pupil to light, but you can still constrict your pupil. If I push my finger close to your nose and your eyes track it, you will still constrict there. So we would say that there is a light near dissociation, right? Because you're constricting for near, but you're not constricting for light. Edinger-Westphal nucleus is just for the light, not for the near. I don't exactly know the mechanism here, but the levator palpebrae is innervated by oculomotor cranial nerve 3. And if that's damaged, you get something called ptosis. Something I don't really understand here is that there's also inhibitory fibers there that are only damaged if you have a lesion of the dorsal midbrain. So you're going to get the opposite. You get this lid retraction, which is known as Collier's sign, like that. And you also have a vertical gaze palsy for reasons that I don't understand. So you have trouble moving your eyes vertically, which means they're a little bit kind of down, and that actually looks a little bit like a sunset. So sometimes these are called a setting sun or sunset eyes. And cool. Reticular activating system is also known as the reticular formation. It's just about maintaining consciousness. So if you damage this, someone might go into a coma. I mentioned the red nucleus earlier. So in the upper part of the midbrain, and it's important, the upper part of the midbrain, not the lower part of the midbrain, we have something called the red nucleus, which does a couple different things, but the most important one is it is going to innervate some of the flexors in our upper extremity. And it's kind of like one of these primitive reflex type things where it always wants to flex. So here's the red nucleus in the superior midbrain, thinking, hey, we should flex our arms. And it's up to your cerebral cortex to say, no, don't do that. That's a really bad idea. Don't flex your arms. And so normally you're just sitting there, you're probably not flexing your arms. What happens if I have a lesion right here? Well, I'm definitely not going to flex my arms then, because even if I wanted to, my red nucleus can't communicate, and so you're going to get this arm and wrist extension. On the other hand, if I have a lesion above the red nucleus, now the cerebral cortex is saying, don't flex, but that message isn't getting through. So the red nucleus left to its own devices is like, oh yeah, I'm going to flex all I want. Flex my arms, flex my forearms, flex my wrists. All right, so here there's a couple different lesions that we're going to talk about. Probably the most important one is internuclear ophthalmoplegia. And if we break that down, internuclear, between nuclei, cell bodies in the brain, ophthalmoplegia, aplesia, paralysis. So it's going to be a paralysis due to communication between neurons. Let's run through this entire lateral gaze pathway. So let's say that our objective is to look to the right. The left frontal eye field is going to communicate, it's going to decussate crisscross. It's going to move over to the right PPRF. This goes to the abducens nuclei. And that is just going to, on this side, say, hey, you know what, let's go ahead and the lateral rectus muscle, cranial nerve 6, let's move this in this direction. That's exactly what happens. But we also need to get the left eye to look medially. So it's also going to move here through the medial longitudinal fasciculus, which is highly myelinated, and just spoiler, if you have MS, this is likely to be damaged. So anyways, we're going contralaterally, again, crisscross. This now goes to the oculomotor, which supplies most of the motor innervation of the eyes, importantly for the medial rectus, so that this can now turn medially, and if this one turns laterally and this one turns medially, you have a unison, both your eyes, this lateral gaze looking to the right. Okay, so that's how if everything works perfectly. But what if this is broken or this is broken, right? Left FEF or right PPRF, nothing's going to happen, right? You're stopping right at the beginning. You don't get any ability to look to the right. Okay, what if we have left MLF3? So in other words, we get the message from here to here, and then we get it from here, and that means this one can go ahead and look. So my right eye has no problem looking to the right, but the message never comes over here across the MLF. So the left eye just sits there. So it technically could be that it does cross, but then the oculomotor nerve is damaged. But more importantly, we can think of the MLF, and this is what we mean when we say internuclear ophthalmoplegia. We can't get between this nucleus and this nucleus, so we get a paralysis. Now, less importantly, but we'll talk about it, you could also have a right cranial nerve 6 issue, where we go from here to here, and then we cross fine, and then we go over here, and then this one looks medially, but there's damage somewhere along here, and so this actually can't look lateral. Good to know. All of these, very important to understand this. This is the most important one. That's what we mean when we say internuclear ophthalmoplegia. All right, cranial nerve lesions. Okay, just recall the rule of 4. So there are 4 cranial nuclei above the pons. There are 4 in the pons, and there are 4 in the medullas, and they all run chronologically. Also, rule of 4, if you are divisible by 12, in other words, 3, 4, 6, and 12, not 1 and 2, because technically they're above the brainstem. 3, 4, 6, and 12 are all midline for the brainstem. We're going to go into this way more depth, but 1 is smell, 2 is afferent visual, 3, 4, and 6 are motor. Trigeminal, we have V1, V2, V3 for sensory of the face. V3 also does muscles of mastication. V7 is mostly going to be facial motor. V8 is sound and hearing. That's vestibulocochlear nerve. 9 is going to be gag reflex, swallowing, the back of the tongue, and the carotid sinus reflex. 10 is going to be the aortic baroreceptors in addition to parasympathetic nervous system, also a little bit of swallowing, the gag reflex. 11 is shrugging your shoulders, turning your head. 12 is going to be sticking out your tongue. All right, so 1, olfactory. Trauma to the face can damage the cribriform plate where the olfactory nerve is, and you can't smell. Okay, no nerve 2. So it's highly myelinated. So MS is going to affect this. An optic glioma can affect this. This is associated with neurofibromatosis type 1. And a pituitary adenoma can, or I guess an anterior communicating saccular aneurysm hemorrhage can cause bitemporal hemianopsia, which is arguably part of the optic nerve. And we mentioned that right there. So yeah, you wouldn't be able to see, or at the very least, it depends how damaged it is. You might lose, a relative afferent pupillary defect. So your pupillary light reflex either completely goes or it goes a little bit. And this is what bitemporal hemianopsia looks like, which we'll talk more about later. I guess soon. So just to recap. So actually, just recall that the left visual field. Actually, I like this picture more. So, all right, we're going to do this on the next one. We'll look at this here. So, things are going to cross at the optic chiasm. So, at the end of the day, everything after the optic chiasm on the right side, everything on the right side after the optic chiasm is associating with everything you see on the left part of your body. And then everything you see on the left side has to do with the right side of right part of your body. So, everything's kind of flipped after the optic chiasm. Even up, down. So we have these dorsal tracts which move up, and they are going to account for the lower visual field. And then the lower visual field, Meyer's loop in the temporal region, is going to be associated with the upper visual field. We're going to see more of this right here. So this is going to be temporal vision. This is nasal vision. And just think about the way that a photon would move, right? A photon is going to move straight in a line like this. It's not going to curve off and go over there. It's going to go straight like this. So it should make sense that the temporal goes over here and then the nasal goes over there. And then similarly here, the nasal is going to go right there and then the temporal is going to go right there. So that's number 1. Definitely get that down. And again, after the optic chiasm, everything I see on the right side has to do with everything that I'm seeing over here. And then everything on the left side is everything that I'm seeing over here on the right side of my visual field. So if you get that, it should make everything go a little bit smoother. So macular degeneration has nothing to do with this picture. Just there's, if you have proliferative diabetic retinopathy, or age-related macular degeneration, you will lose. You'll have a scotoma. You will lose the center of your vision. All right, now let's go ahead and look at this thing. If I damage right here, I'm taking out the whole optic nerve. I have total blindness in one of my eyes. If I have a pituitary adenoma or cavernous sinus thrombosis or anterior communicating saccular hemorrhage, I am going to have bitemporal hemianopsia. It's quite common. Prolactinovas are quite common. If you damage just a tiny little portion right here, okay, if we track this portion here is on the lateral side of our retina. And remember, the lateral side of our retina is receiving input from the nasal field right there. So this would be an ipsilateral nasal hemianopsia. Now, if we damage the whole optic tract, remember, everything after the optic chiasm, everything on the right side over here has to do with the left visual field. So D, we're seeing that we're losing the left visual field and the left visual field. I just can't see anything on the left side of my body. E, we said that it's kind of flipped, right? The dorsal is going to do the lower part of your body, and this is going to be the parietal lobe. And then Meyer's loop is going to be the lower one that goes to the temporal lobe, but again, it's flipped. So that's going to be the upper part of your vision. So this and this respectively, just a quarter, because we're just dealing with one of the tracks at a time. A PCA stroke, or an MCA stroke, the macula is very important, that part of the region that's processed in the occipital lobe, so it gets a dual blood supply. It's not like a watershed infarct. It is like super well supplied by both sides. So if one side goes, then the other side can compensate. So you would lose, if you have damage over here. Again, the right side of my, the right occipital lobe is going to deal with the left side of the vision. So I'm going to lose all of my left vision, except for the center, because again, we have this macular sparring because of the dual blood supply. All right, we should know all of this. Most everything is just going to be cranial nerve 3. Medial rectus, inferior oblique. Inferior oblique does exactly the opposite of what it says. Inferior oblique pulls up. But unlike the superior rectus, it pulls up and medially. And the superior oblique by cranial nerve 4 is doing the opposite of what it sounds like. It's superior, but it's pulling it down. It's pulling it down, and it's also pulling it in. More oculomotor, we have the inferior rectus, and then we have the superior rectus. So pretty much everything except SO4, and then the abducens, which is 6. All right, so cranial nerve 3 can get damaged. It's really important. It innervates a bunch of different things. It can also be damaged a bunch of different ways. If you have a mass effect or tumor or hemorrhage, uncal herniation can push right into it right there. And remember that there's the parasympathetic fibers from the Edinger-Westphal nucleus for pupillary constriction that lie on the periphery of it. So most of these things are actually going to damage the PNS before they damage the cranial nerve 3. It's usually actually going to get both of them, but theoretically the PNS would be the first to go. So same goes for a PCOM aneurysm, which would damage this if I have a little, barisaccular aneurysm that blows up. The cranial nerve 3 goes to the cavernous sinus. So if there's a thrombosis, that's also going to compress again on the outside first. But again, usually we'll get both of them. So it's usually going to be a bundle. What might be kind of the exception is that if you had ischemia, because it's on the periphery and the blood vessels are right here, they're going to supply the PNS first. And so if there's a shortage, the PNS is going to be fine, but it'll be the cranial nerve that gets just screwed up. So if you have a down and out pupil, which would be cranial nerve 3, and you have a normal pupil, then it's likely due to ischemia. If you have mydriasis, which is going to be so the meiosis is small pupil, mydriasis is a large pupil. Large pupil is going to be any of these other things, which is probably more common. So down and out pupil, or down and out eye with a large pupil tells me that it's any of these 3. And that's called a blown pupil. You also get ptosis because we supply the levator palpebrae, which is going to be like retracting the eyelid, pulling it back from the cranial nerve. And if we don't have that, then it just kind of falls down a little bit. So I think of SO4 for cranial nerve 4 and the superior oblique. Remember, superior oblique pulls down and in. And this could be a medial midbrain aneurysm. It also goes through the cavernous sinus, so thrombosis there would affect it. Down and in, when you're looking down and in, well, if I'm looking at my iPad right now, or if I'm reading a book, if I'm walking down the stairs, and so people might tilt their head to the opposite side to accommodate so that it's actually kind of looking where we want it to look. Abducens is going to abduct, is going to pull laterally. This is also going to be medial pons, also cavernous sinus thrombosis, can't look laterally, and it might even look in a little bit if you're just looking straight ahead. So notice we skipped over 5 because I'm doing all of the motor innervation to the eyes first. So let's go ahead and take a look at this. We're only talking about the right eye, so only look at the right eye. Like, in other words, don't look at this side, don't look at this side, don't look at this side, don't look, and don't look. Let's just look at the right eye. Okay, so this is a cranial nerve 3. So I should have, let's just look at the primary position. It's down and out because I don't have a medial rectus to pull it inwards, and I don't have a superior oblique to pull it upwards, and so it's going to go down and out. What about if I want to look to the right? Well, that's actually fine because I can, the lateral rectus is fine. But again, notice we always have this ptosis going on, so we can really immediately tell. What if I want to look to the left? Well, now I don't have a medial rectus. I can't look to the left. All right, cranial nerve 4. So this is going to go, normally it's going to help your eye pull down and in the SO, superior oblique. And if you can't pull down and in, it's kind of going to go up and out a little bit. So you can kind of tell that there. You can look laterally fine. That's the oculomotor, so that does not really affect it. But here, if I say, hey, can you look in? We have a hard time looking in, or at least in and down, because we don't have this superior oblique. So the oculomotor nerves, inferior oblique is going to pull it up and in. That's the only way you can get this eye to look medially. Okay, what if we have an abducens of I6? So abducens, even when we're midline, notice that it's a little bit on the medial side because, the abducens nerve and the abducens nerve going to the lateral rectus, it's not like the lateral rectus only works when I'm looking to the side. That's when it's working more, but it's always working a little bit just to kind of maintain a homeostasis. So if I have that taken out, it's going to be a little bit of an inward deviation. That's what we see here. What if I say, hey, can you look to the right? Well, then it's really apparent. I can't look to the right at all with that eye. It's just staying straight ahead. And if I say, hey, can you look medially? Then yeah, medial should be fine. All right, trigeminal. So trigeminal is going to be mostly face. So also going through the cavernous sinus. Tumor, brainstem, vascular. I guess you could say that for any of these. You can't feel your face. You get trigeminal neuralgia if, someone's brushing their teeth, they're shaving, and somehow it just causes this really severe, intense, brief headache that might be arrhythmic, right? It might come and go and come and go and come and go, and it's apparently quite awful. Back to the nerve, though, and what happens if we have a lesion. Sensory issues to the face, but it's also sensory to the anterior 2/3 of the tongue. What do we mean sensory? We mean, this porridge is too hot, right? Not it's tasty, not it's not tasty, it's too hot. Also, V3, the mandibular nerve, is for muscles of mastication. And so your jaw actually might deviate to the side where you have the infection or lesion or whatnot. Most of these things are going to deviate towards the side of the lesion. We'll see a few where they go to the opposite side. Usually it's going towards, so when in doubt, that would be a good guess. So we're now, we're still in the pons, but you notice that 4 and 3 we're going to be medial because they're divisible by 12. This is not divisible by 12, so it's going to be a lateral. And a lateral stroke here would be the AICA. You could also have Lyme disease, also a parotid tumor. The facial nerve innervates all of the, most of the glands of the face, except the parotid tumor, which is weird because it goes through the parotid tumor. But that's why it goes right through the parotid tumor to get to the face, and so if you have a tumor there, that could damage it. HSV is known as Ramsay-Hunt syndrome. I think that's what Justin Bieber has. I don't really know. You're going to have facial paralysis. The orbicularis oculi isn't working, so you can't close your eye. It's kind of, sort of, not exactly the opposite ptosis. That's more the Collier sign, but you're going to have this extra wide eye. You're going to have drooping of the face, and it's going to be like you had Botox in your forehead. It's going to be quite smooth. Taste. This porridge is delicious, and it's very sugary, and I love it, to the anterior 2/3 of the tongue. Remember that a lot of the glands, I think it's the chorda tympani or something, is some branch of the facial gland. Facial nerve is a lot of the salivation and taste. Also hyperacusis. So the stapedius muscle, which is going to help the stapes of the ossicles in your middle ear, It needs to be regulated by this muscle, and this muscle is innervated by the facial nerve. And so if you don't have it, things might sound super loud. All right, Bell's palsy is going to be cranial nerve 7 palsy. Not to be confused and highly tested, the difference between this and a stroke, a frontal stroke of the MCA. Remember, the MCA is going to be arms, but also face. And so an MCA stroke is going to have a lot of same symptoms as a cranial nerve 7. The main difference, the way you differentiate it, is the facial palsy, Bell's palsy, cranial nerve 7, the forehead has had Botox. And here the forehead is fine. Both these foreheads look the same. So the forehead is actually spared if you have a stroke. Why? For whatever weird reason, you're going to have dual innervation for your facial muscles from both sides of the body, only for the forehead muscles, like the temporalis. So in other words, like, let's say this is my orbicularis oculi, and this is my, I don't know, all the muscles going to my mouth and stuff. So if I have a stroke over here, this isn't working, that's not working, none of that's working. So none of this stuff is working, so we get all of this drooping, and the eye might be a little bit more open. But the temporalis, which goes to the forehead over here, it gets the supply from that. Well, that doesn't work, but it's also getting a supply from here. We have this dual supply, so my forehead, I can still wrinkle it, I can still move these muscles, so it's not going to seem relaxed and smooth. Because remember, Botox is just doing paralysis, so it's kind of mimicking. But if I have a cranial nerve 7 lesion, it doesn't matter where my innervation is coming from in terms of the left or the right brain. I just can't get the message through no matter what. So you will have paralysis here, and you will have paralysis here. Vestibulocochlear. Vestibulo is balance. Cochlear is going to be for hearing. So we are going to have vertigo, the balance, and then tinnitus, so like ringing in your ear and maybe a little bit of deafness. How do you get this? So the cranial nerve 8 is a little bit tricky because it's kind of actually in the border between the pons and the medulla. It will be lateral, right, because it's not divisible by 12. So it could be the AICA or the PICA, which is Wallenberg syndrome. So, I mean, it could also just be tumor. You get smacked in the ear. It could be an infection. It could be a schwannoma, which is associated with neurofibromatosis type 2. We'll get into this, I think, at the end of the lecture. We talk a lot about different ways you can have. This would be sensory neural hearing loss, but also vertigo from the vestibular portion of the nerve. Glossopharyngeal, glossotongue, pharyngeal, pharynx. It's going to the posterior 1/3 of your tongue. It does sense, so like temperature and taste. It also goes to the pharynx, so it's important for swallowing, so you'd have dysphagia, no gag reflex. Remember, the reflex is usually the smaller numbers for the sensory and then the higher numbers for the efferent, the motor component. So cranial nerve 9 is the sensory, and then in the vagus, cranial nerve 10 is for the motor. The parotid, we said the facial nerve goes through it, but it doesn't supply it. It's the glossopharyngeal which does supply it, so you won't have parotid gland functioning. Also, it's going to regulate the baroreceptors and chemoreceptors of the carotid sinus, so this could affect your heart rate and your blood pressure and whatnot. If you have a lateral medullary stroke, which is actually quite common, the PICA, this is a Wallenberg stroke. Vagus nerve is also going to be a lot of swallowing and your gag reflex. It's actually really similar to the 9 in a bunch of ways. Instead of the carotid sinus, it's the aortic arch receptors that this is interacting with. Remember that the recurrent laryngeal nerve is going to tuck under the aortic arch and go back to supply the voice box. And so if you have damage to the vagus, you're going to have damage of the RLN, and so you're going to be hoarseness. This is a dead giveaway if you see this. All right, so remember, most things go towards the affected side. So it's also important for elevating the palate. So if I have a right palate that is not elevating, it's down a little bit. So actually, let's look at this here. That palate is not elevating, right? This palate is elevating. This one is not elevating. So I know here that the vagus nerve on this side is the one that's affected. Notice that the uvula goes over to the other side right here. It's going across. So that is one of our few unaffecteds. This is also in the same region for the medulla. It's the lateral because it's not divisible by 12. So this is medullary. I think of medullary 2 L's and Wallenberg is going together. Here we have a picture of this palate and the uvula deviation. Also really important for supplying the parasympathetic innervation of the GI system. The accessory nerve, this comes up from the cervical plexus through the foramen magnum, and then it is going to go down through, I think the jugular or something, but in any case, if you damage the cervical plexus, this is going to damage the accessory nerve. The sternocleidomastoid, the SCM, is important for turning your head to the opposite side. So this is another one of our opposites, turning the head to the opposite side. the SCM is on the same side, but it turns to the other side. And then the trapezius. So I guess if we're looking at this right here, the trapezius for shrugging your shoulders is going to be damaged. So your shoulder is going to drop on this side. Notice how this is lower than this. And it's also going to cause a winged scapula. So the trapezius, winged scapula, and the shoulder is going to be lower. And the SCM damage can turn your head to the opposite side. Glossopharyngeal. No, this is not. This is the hypoglossus. Nice try. Hypoglossus, hypo under, glossus tongue, under the tongue. And that's where it innervates, but it's actually important for motor innervation of the tongue. So it pushes the tongue out. And if you can't push out, so if here we have a left cranial nerve 12 lesion, well, these muscles are going to waste away because they're not being innervated. They can't be used. They're just going to atrophy. So you can see that muscle wasting right there. But we're going to deviate, like many things, towards the side of the lesion. People say lick your wounds for this because the lesion is on this side and it's kind of like trying to lick its wounds is the idea. This is in the medulla. This actually, I think, would be a medial medullary stroke. So I don't think that's lateral, but an anterior spinal, I guess you could get an anterior spinal injury. So that would be the issue here. But it could as easily be something like a tumor or just trauma. Okay, now pivoting to lesions of the spinal cord. All right, three major tracks we're looking at. Corticospinal, I think brain needs to plan movements. This has to do with motor. This is a descending pathway. This is over here. Dorsal column, it's the dorsal column of the spinal cord. It's the medial lemniscus when we get into the brainstem. I think of dolphins. Dolphins are very evolved and, they have fine touch and proprioception, all that fancy stuff. So this is proprioception, discriminatory touch, and it, as the name implies, is in the dorsum. And the spinothalamic tract, I think of people get spine injuries, the first thing they say is, I can't feel my legs, right? Crude touch, pain, and temperature. This is right here on the anterior side. Decussation, all of these are going to have interesting crisscross. Is really important to get these. So the dorsal column and the corticospinal tract are similar in that they will both decussate at the medulla. That is to say, if I have a, like my right brain wants to tell my left arm to do something, the axon moving down the right part of my brain until it gets to the medulla, then it crosses over. Now it's permanently on the left side until it gets to my left arm. And same thing, if my left arm is feeling a vibration, that is going to move up from my left arm up the left part of the spinal cord. It is going to decussate to the medulla, and then it's going to go to the right post central gyrus to relay that information. The spinothalamic, though, is different. The spinothalamic is, for the most part, going to, right where it comes into the dorsal part of the spinal cord, it is going to cross over at the anterior white commissure, right at that level, and then it's going to go up and forever stays on the other side. A little bit of an exception that it sometimes can escape through something called Lissauer's tract, where it can actually go up here 1 or 2 levels before decussating over. Crude is just, hey, can you feel it when I'm poking you or scratching you or whatever? Fine is like, oh, can you differentiate a poke there versus a poke there? Can you differentiate me poking there versus poking there? That's discriminatory touch. Motor neurons, we have upper motor neurons, which is just a 2-neuron system, so it's easy. Notice the decussation at the medulla. It's everything from the brain to this right here, to this anterior horn neuron soma. And then everything after that is just going to be the lower motor neuron. So blue, upper motor, red, lower. So if you have an upper, the brain is usually trying to tell the rest of the body, like, hey, cool it. You don't need to flex so much. You don't need to like do the Babinski, like stop. It's kind of a party pooper. It's a wet blanket, right? So if we have an upper motor neuron injury, it can't tell the rest of the body what to do. So the muscles just go crazy. The lower motor neurons are constantly firing. So everything is up in an upper motor neuron injury. We're going to have more reflexes. Our tone is going to go up because the muscles are contracting. We're going to have Babinski, is the foot is going to go up. It's the positive Babinski sign. Now, this is a little different now. The spasticity, it's called a clasp knife. So if you guys have ever opened a knife, it opens slowly, and then all it's sudden at once. Slowly. Sorry, my red is probably not helping. And then all at once. Same thing here. Look at this person. It's going to go slow, resistance, and then it goes, right? That is a clasp knife spasticity. It's upper motor neuron sign. No fasciculation. So a fasciculation is that the muscles are always like without any innervation, even from a lower motor neuron, the muscles are just going to twitch every now and then. So these are just random twitchings. So this sounds like it would be upper motor neuron, but no, this is actually a lower motor neuron. It's just random twitchings if there's no innervation. So we don't have these here. We do have this here. And as we said, there is the clasp knife. So I guess this is kind of redundant. Everything is down here. It's down because there's atrophy. We're not using these. Babinski's are down, as they should be in any case, actually. And then we have a flaccid paralysis. So just spinal cord, if you have damage to the dorsal side, proprioception, it's going to have balance issues and fine touch. The thoracic region on the lateral side, we have these sympathetic columns, so you get like a Horner syndrome or any sort of sympathetic deficiency. Cortico, remember that's brain. We want to do movements, so this would be upper motor neuron. Really anything in the spinal cord for the most part, except for the anterior horn and the brain, is going to be upper motor neuron. Anything going from the anterior horn to the muscle is going to be lower motor neuron. That's on the anterior side of the cell bodies. Spinothalamic is also on the anterior side. This is pain, temperature, crude touch. Just can you feel this or not feel this? And the dorsal root ganglion is going to be for both the spinothalamic and the dorsal tract. And this is going to be for deep tendon reflexes too if this is damaged. So deep tendon reflex is like, let me bang on your knee with a hammer. And if your patellar reflex activates, that tells me that L3 is working. You should be familiar-ish with the dermatomes and the myotomes. We talked about this last time. And you're going to be a paraplegic if you have a lumbar injury and, a quadriplegic if you have some sort of cervical injury. You should know these reflexes as well. We'll go through them quick. C5 bicep, C7 triceps, L3 is going to be the patellar, and then L5S1 is going to be the Achilles. There's a little bit of overlap between a couple of these. All right, so these are really common, like syndromes, diseases, manifestations of, causes of spinal cord lesions. So we can really differentiate these with this Venn diagram and about which tracts are affected. So ALS is going, Lou Gehrig's disease, this is all motor. Polio, all motor. SMA, all motor. Friedreich ataxia, that's actually a little complicated. I think it's mostly motor. ASA is going to be a little bit of motor, a little bit of spinothalamic. B12 deficiency is mostly going to be proprioception and dorsal, but it's also a little bit of the motor neurons as well. Tabes dorsalis is like famously just proprioception in the dorsal column. Syringomyelia, this is, unless it gets really way huge in like the thoracic region, right, associated with Chiari type 1, this is going to be the just the spinothalamic. Maybe it's more reasonable that it gets to the lateral horns as well. And then Brown-Séquard is going to get all three of these. It's going to be a hemisection where it's just hitting kind of like one side of the spinal cord. All right, so let's start with the hard one, the Brown-Séquard. All right, so somebody hits us with a lightsaber right at this region right here. How can we figure out what's going to happen? Let's just start with, so there's our dead end, right? That's where we got stabbed. Corticospinal goes up, it crosses the medulla. What does that mean? That means that that tract has no way to get through that roadblock. So I cannot move any of the muscles of my lower right leg. And if these axon tracts can't move, that is going to be upper motor neuron signs. Notice that at the site of the lesion, we're actually damaging the ventral horn. So that is actually going to be a lower motor neuron sign right at the level of the vertebral level of the lesion. But for the most part, it's going to be upper motor neuron signs. All right, what about the dorsal column? That does the exact same pathway. It also crosses the medulla. So I'm also going to have issues with proprioception and vibration, discriminatory touch on that side. All right, what about the other side, right? Because remember that the spinothalamic crosses the anterior white commissure at the level where it enters the spinal cord on the dorsal side. So we won't be able to feel anything on the contralateral side in terms of pain or like temperature, just like crude touch. But notice that, wait a second, shouldn't this be affected? Because it's supposed to, the nerves that are going right here, shouldn't they cross right over? And, if they decussate at that level, shouldn't this also be affected? No, because remember, we have Lissauer's tract. It actually goes up one or two levels and then crosses. So it actually misses the dead end. So that's why you're going to have this like slight asymmetry in terms of like one or two vertebral levels up or down when you have the Brown-Séquard syndrome. ALS, upper and motor neuron degeneration, doesn't affect sensory at all. It's linked to a couple different gene mutations. One of them is in superoxide dismutase, so I guess there's just way too much oxidative stress and that damages certain cell bodies. No cure. It hits people in their like 40s or 50s and is a 5-year life expectancy. Quite awful, and eventually they're just going to have inability to speak and eventually respiratory distress. The diaphragm's not working. You're going to get this from the water. There's fecal oral transmission, and it's just going to be lower motor neuron symptoms because it's destroying the anterior horn like cell bodies. And you can detect this, if you see like white blood cells or proteins or just literally straight up the virus. If you do a lumbar puncture and check the CSF, that can help make the diagnosis. Spinal muscular atrophy. So it's called floppy baby syndrome, and it's actually quite similar. You're gonna have lower motor neuron symptoms. So remember that lower motor neuron is this is the floppy flaccid paralysis, right? Because there's just because normally the lower motor neuron wants to flex the muscle, and it's the brain that's stopping it. But if I can't even, the lower motor neuron injury means that the lower motor innervation doesn't even reach the muscle, then there's just no muscle action other than a couple of silly little fasciculations, nothing. That's why you get these floppy babies, for lack of a better word, and is probably going to be diagnosed very early. It's related to the SMN1 mutation, which is a small nucleoribonucleoprotein. I have no idea what it does. Friedreich ataxia. This one's a little complicated. I think it's a little bit of upper motor neuron, a little bit of lower motor neuron, but in all honesty, I'm just not too sure. So a couple things to know though. Trinucleotide repeat expansion, like Huntington's. So this is very high yield, important to know. The frataxin protein is going to help with iron metabolism, and if this is going awry, then you're going to be extra susceptible to oxidative stress. Cardiomyopathy. So HCM, hypertrophic cardiomyopathy. You might just have somebody drop dead in like their 15s, 20s, or whatever. Areflexia. So again, this would be a sign of a lower motor neuron injury, but they're also supposed to have a spastic paralysis, which is a sign of an upper motor neuron injury. So I'm not exactly sure what to make of that. So they have ataxia, and that is because the spinocerebellar region, this is actually a fourth one that we're not really talking about so much, but spinocerebellar is going to the cerebellum. Cerebellum is for gait, and that's where we get the gait and ataxia issues, hence the name ataxia. They have scoliosis, and they have this kind of like large arch to the foot, which we also see in Charcot-Marie. I think it's Charcot-Marie. And they get diabetes as well. Vitamin B12 deficiency, also known as subacute combined degeneration, at least when it's affecting the spinal cord, it can also affect the peripheral nervous system. So we mentioned earlier that B9 is folate. You take it if you're pregnant. B9, B12 kind of work in union, though, to help methylate things. So why is this one different? So B9, you run out of B9 quickly, especially if you're pregnant. But for B12, for the most part, you have like tons. You have years of stores of B12. But if you have a really, really, really strict vegan diet, B12 is one of the few nutrients that you cannot get from a vegan diet. You'd have to take supplements. So if someone's a really strict vegan, not like on Christmas I had some ham, they're really strict, this could be an issue. More likely, they have pernicious anemia, where you get autoimmune destruction of the parietal cells, which make intrinsic factor. Intrinsic factor is necessary to bind to vitamin B12 to help it be reabsorbed in the small intestine. Or if let's say you get gastric bypass or something, or you have Crohn's disease or ulcerative colitis, then you're going to have issues of absorption, and so that's going to kind of be similar to B, is that you can't absorb B12 even if you do have intrinsic factor because the small intestine's all screwed up. It's necessary to make uracil and thiamine for division, but also to turn ethanolamine into choline. We need choline and myelin. That is one of the reasons that it's going to affect the spinal cord. We're going to have a demyelination of it. It's going to affect the corticospinal tract, so there's going to be some upper motor neuron symptoms, the dorsal column, so fine touch vibration, and then the spinocerebellar tract, you're going to have ataxia. Also causes megaloblastic anemia and these hyper-segmented neutrophils as well. Tabes dorsalis, so this is just tertiary syphilis. So you get syphilis, and it just, the disease progresses and evolves over the years and decades. So this is tertiary syphilis, also known as neurosyphilis. It's going to demyelinate the dorsal column. So proprioception, fine touch, way thrown off. And the Romberg is a great way to diagnose this. So Romberg, remember, is just, we just have somebody stand. All right, can you just stand normally? Remember, there's three things to come in with standing and coordination of like the trunk. And that is vestibular inputs, that is the eyes with vision, and that is the proprioception from the dorsal column. And you need 2 out of these 3 to work. Let's say you close your eyes. Well, you or me, assuming that we're fine, we're not going to lean over. We should be completely fine because we took away vision, but we still have proprioception. We still have the vestibular system. But if your dorsal column is not working, you have advanced syphilis. Then when you close your eyes, you are now taking away the proprioception aspect, and you've closed your eyes, you're taking away the vision aspect, and you have these 3 things. You need 2 out of the 3, and all you've got left is the vestibular system. That is not enough. You're going to start teetering, and you might fall over. The doctor might even push you and really cause you to fall over. So that's how the Romberg works. Very important to know that. For whatever reason, this also affects the Edinger-Westphal nucleus. So your pupils will not respond to light. So I shine a light in your eye and there will be no constriction of the pupil. However, that is a different system, a different reflex arc than if I bring my finger close to your face and you track it, and then your pupils are going to constrict. So this is called light near dissociation, where you do not constrict to light because the Edinger-Westphal nucleus is destroyed, but the different pathway that I'm not familiar with still allows you to constrict for the near like accommodation reflex. And again, I don't know exactly why tabes dorsalis affects the Edinger-Westphal nucleus, but it does. You also have lots of pain, and we mentioned these right over here. Okay, anterior spinal artery stroke, not to be confused with these 2 PCAs over here. This is mostly going to be the spinothalamic tract, although it's going to hit the corticospinal tract a little bit as well. So if you have a stroke of the vertebrae, the vertebrae are going to feed off to make this anterior spinal artery. It could just literally be a stroke of the ASA, or maybe an aortic aneurysm repair is going to leak blood and compress this and cause damage there. So at the level of the lesion, we're always going to have lower motor neuron because we're actually damaging these anterior spinal cell bodies. But below this, we're just affecting the tracts, which means the cell bodies are still fine, and they're going to be unregulated, no inhibition from the cortex, and they're going to fire like crazy. So everything is up in the upper motor neuron. That's going to be below the lesion. So high tone, high reflexes, etc. So we're going to lose on the contralateral side the pain and temperature. But again, it might be the same we saw with the syringomelia. It might be like a level or 2 below because of Lissauer's tract for the spinothalamic. You could, if you're in the mid-thoracic area, actually be spared because you have collateral circulation from some random artery called the artery of Adam Kiewicz. I'm sure I'm pronouncing that incorrectly. All right, syringomyelia associated with Chiari type 1, the less severe one. So things want to cross the anterior white commissure. This is mostly going to be in the thoracic region. And so that's why you get a cape-like distribution, right? Because it's in the thoracic region, and it's just affecting the, what crosses over here, which is the spinothalamic tract, which is just pain and temperature. So you have this cape-like distribution where you can't feel any pain and temperature. Why doesn't it go all the way down? Because it's just this large cyst that just goes right there, and it's just in the center. So depending how big the cyst is, it could go from, T1 to T3, or if it's bigger, go from T1 to T5. And remember that if it gets really, really, really big, it could also hit the lateral horns and cause a Horner's syndrome where the sympathetic innervation is lost. Cauda equina, so very severe back pain. And recall that these nerve cords are actually, these are downstream of the anterior like the ventral horn cell bodies. So these are the lower motor neurons that we're actually talking about. They're bundles of them going from the spinal cord to the muscles. So we get severe back pain, but you're going to have the lower extremity first it's going to be lower extremity reflexes because this happens after like L1 and L2. So it's going to be, the L1, L5 is going to be the anterior part of the leg, and then the S is going to be the posterior part of the leg and like the genitals and the perianal region. But we're going to have lower, I don't know if it says this here, this is important, we're going to have lower motor neuron issues specifically. And so there's weakness and sexual dysfunction, urinary incontinence, and perianal pain, probably, not a question mark. And yeah, cool. There you go. Strokes. Okay, strokes, very high yield and very high yield for a reason. So if we want to put strokes under the umbrella of cardiovascular disease, it can be associated with the number one cause of mortality. If you want to separate it, then it's going to just on its own going to be the number 4 cause of mortality. It's a big one. It's up there. And even if you survive, 50% of people are going to be chronically disabled. I mean, speaking from an experience, this is a real motherfucker, this disease. 3 out of 4 of my grandparents all suffered strokes. None of them died from it, and just a huge impact on your quality of life. My girlfriend's father, it's just awful. So you're going to see this all the time. You know, we go over some really obscure, like, you know, neurocutaneous diseases. You might never see a patient or see a couple patients your whole life. You will see a ton of people with strokes. So 2 different types of strokes. There's ischemic strokes where there is just not enough blood supply getting to an area. This is by far the most common one. This is 85% of strokes. And then we have hemorrhagic strokes where there is a bleed in the brain. It's not contained. So we can go ahead and break this out to a little bit more of a complicated like web. I think it's really important to have all of these organized in your mind. So ischemic, we have embolic, so like an embolus, a clot that is traveling from a foreign region. A thrombus, just, you know, you have atherosclerosis and you're just building up like a clot in the local region. A lacunar stroke, so this is going to be ischemia of a really small vessel. It leaves a little hole, little lacunae in the brain. And then a hypoxic, so let's say you get shot with a gun and you're bleeding a lot, you get a hypovolemic shock. You don't have enough... you're having a hard time adequately perfusing the brain, so you can get a hypoxia there. And it's going to affect watershed regions, which we'll talk about. And this is also just going to be very much in the basal ganglia. I just want to say that now. We'll say that again later. Hemorrhagic. All right, so we got epidural and subdermal. Both of these are hematomas. So this is going to be from trauma. And then subarachnoid and intracerebral are going to, not always due to aneurysm rupture, but often associated with rupture of an aneurysm. Ischemic strokes can become hemorrhagic strokes. So there's like a reperfusion injury. So if there's ischemia to a tissue, I'm not exactly sure why. I'm sure a lot's going on, but I always just thought like if there's ischemia to an area, the vessels get weak and damaged because they're ischemic. And then suddenly if we have tons of blood flowing in, it might be more pressure than that like kind of weak tissue can deal with. And it might cause like a rupture. And so that might be a hemorrhagic stroke. I'm sure there's a lot more going on there and maybe that's totally wrong, but that was what I thought. Vasospasm. So we can go the other way. Hemorrhagic stroke, if we're losing blood, there's a lot of chemicals in the blood that's getting into the surrounding interstitial fluid that can affect vessels and cause them to constrict. And if they're constricting, then that means downstream of that, we're not getting enough blood flow. So this can cause ischemia. All right, so again, 85% ischemic stroke, far more common. We have thrombotic, and so this is just going to be the usual suspects. What is promoting atherosclerosis, smoking, obesity, etc. And so it's usually arterial thrombosis. You could also have venous thrombosis. Certain people have genetic mutations or taking oral contraceptive pills or whatever that are, or they have cancer, something that's putting you in a hypercoagulable state. Then we have embolic strokes. So usually this is coming from the carotid artery. Because most deep vein thromboses are going to get caught by the lungs coming from the legs. But it could, if you're coming from the legs and you have a PFO, patent foramen ovale, it could go right through from the right atrium to the left atrium, left ventricle, then pump right up to the brain. Or if you have atrial fibrillation, you can have blood stasis, you can get a clot, that can go up to the brain. Or if you have infective endocarditis on like your mitral or aortic valve, this is thrombogenic and this could cause a clot and that could go to the brain. Lacunar, we said again, is going to be the small but deep penetrating arteries off of typically the lenticulostriate arteries off of the MCA, which is again is feeding the basal ganglia. A lot of different reasons: hyaline arteriosclerosis, microatheromas, fibrinoid deposition, and they leave these little lacunae, these little holes, these lakes. MCA is just the most common. Just note that's so important. It's the most common one. It's so common. You guys have probably heard the acronym FAST. I used to be an EMT and we had FAST, right? Someone's having a stroke. How do we know? You see the face drooping, you see the arm weakness, having difficulty with speech, and then time is just critical. Well, this fits perfectly with an MCA stroke, right? This acronym was literally made because most strokes are MCA strokes. if you have a, Wallenberg syndrome, lateral medullary stroke, that's not going to cause these symptoms. If I have an ACA stroke, it's not going to cause these symptoms. The reason is that the MCA is going to be over here, and this is the arms, as we can see, and this is the mouth and throat. So we're going to have trouble with speech, and the face is going to droop as well. So that's why they just connect that with this mnemonic. That's just really highlighting MCA is the most common. All right, lacunar strokes back here. So lenticular striae off the MCA, go figure, right? So the MCA is the most common stroke, and so it kind of makes sense that one of the smaller vessels branching off this is also going to be quite common. It can affect the corona radiata, which is just these axons projecting down from the cortex. The internal capsule, which might be under the umbrella of the corona radiata, I'm not sure, but this is going through, I think it's right, this is the lentiform nucleus right here, and maybe this is the thalamus, but just in the basal ganglia, we have this little stretch where axons can move through. It can also be the pons, but I would typically associate it with the basal ganglia. Probably the internal capsule is the best one. Cortical signs are absent. So what is a cortical sign? Something like, okay, I have a stroke in my, let's say I have right arm weakness, right? I have right arm weakness. Okay, that could be the left MCA, right? But if it's the left MCA, it might also hit Broca's area. So maybe you're trying to wonder, like, why is Will having a hard time speaking? Is because my MCA, it could be Broca's. Let's just say it's going to be the Broca's area is damaged. So I'm having trouble forming words. That won't happen if I had damage to the left internal capsule. Right, the left internal capsule might also go to the right arm, but you're going to not have any cortical signs. That's what we mean. So this is not going to be cortical signs. So aphasia or something like visuospatial neglect, right, where you can't recognize faces or make sense of things, etc. And watershed region. So let's imagine you have a town, and it's, there's electricity being supplied to some big city over here. This is city number 1, and a bunch of electricity being supplied to city number 2. And this town is like really far out in the middle of nowhere, that it's like barely being supplied by both cities. So if one of the cities goes down, or if like there's just like, let's say there's like a war in Ukraine and we're having a hard time getting like, energy for a good price, this town might be a little bit screwed because it's kind of like, it's far away from both of these places. And we're seeing that here. We're looking at this watershed region. This tissue is kind of being perfused by this city and kind of being perfused by this city. But if you have less perfusion because you've been shot and you're bleeding out, you're going to have tissue being deprived of oxygen there. Again, this is not to be confused with something like the macula part of the occipital processing, where it's not that it's in between two big cities. It's like being very much supplied by two cities. So that's going to be collateral circulation. That's different. All right, we've already kind of answered this. What happens if there's global hypoperfusion? These watershed regions, something like in between the ACA and the MCA. Oh, let's look what's in between the ACA and the MCA, right? The green is for the MCA and yellow here is for ACA. Something like the hip, the trunk, the shoulder are all going to be affected. You get something called the man in a barrel syndrome, where you have a hard time moving your shoulders and hips, and you're going to have this very notable way of moving and walking. You could also have something in the PCA and the MCA. I don't actually remember what my point was, but really I just want to emphasize this macular sparing because it is not a watershed region. It's super supplied by two different regions. Not a watershed, but I would just know the cerebellum and the hippocampus are very, very, very hungry for nutrients, and so very vulnerable to ischemia. Whenever you have tissue damage, it's almost always coagulative necrosis, except for the brain. For whatever reason, lysosomes spill out and causes everything to become what's called liquefactive necrosis, and it just sort of liquefies right there. All right, so let's say I do have liquefactive necrosis. I do have some damage to the brain. There's ischemia or hemorrhagic stroke or whatnot. Just what's going to happen? Well, we can same thing we did in the heart, same thing we're doing in most places. We're just, imagine that Times Square gets attacked. Times Square gets attacked by terrorists. You're going to have damage. You're going to have SWAT teams come on. And then, like the SWAT teams are going to come on the day, a few days. And a couple of weeks, months later, SWAT team leaves, but the police officers are going to patrol the site in case there's another attack and just to make sure that, the construction crew can get around and whatnot. Construction crew is then going to repair everything. And at the end of the day, it's going to be repaired, but maybe we have some sort of like memorial, some way of remembering it. So what the heck am I going on about? Initially, you're going to have eosinophilic cytoplasm with pycnotic nuclei. In other words, you're going to have these red neurons, not red nuclei, but red neurons. And this is because nissl bodies, rough endoplasmic reticulum fragments, have RNA. RNA is an acid. Acids stain with blue basophilic stains. So if we don't have those, they're chromatolysis, they're being degenerated. I'm now going to have just red left over. Then the neutrophils are going to show up and going to contribute to the necrosis. So there's our neutrophils. The macrophages or the microglia in the brain, they're going to come over and just patrol. So again, we're going to have like first 24 hours, couple of days to a couple of weeks, couple of weeks to a couple of months. The astrocytes and reactive gliosis is going to come in to repair everything. And at the end of the day, this is the microglia. This is the reactive gliosis. I might have screwed that up. And at the end of the day, you're going to have some sort of all of this, these fibroblasts laying down like scar tissue, basically. And so that's the memorial, or the fact that we didn't ever fully heal our city, is that we have this. And it's debatable whether or not reactive gliosis is good. I think we should kind of lean towards it being maybe a bad thing here. A TIA is a transient ischemic attack. So it's kind of like angina. Angina is like just heart pain, but it's not like a full heart attack, a STEMI. And this is kind of similar. It's like a mini stroke without significant infarction. So remember, infarction is blood is cut off and you get necrosis. Ischemia is just you get deprived for a little bit. So it's going to be ischemia, a little bit of infarction, but not much. It's just going to be a brief focal neurological episode that lasts about like 15 minutes or less. The thing about this, though, but it's an omen. It's maybe we could call it a wake-up call, but maybe it's a little bit too late. If someone has a TIA, maybe they're fine, but I think 50% of people have a much bigger real stroke within the next 6 months. So, maybe they can radically change their diet or start medications, or maybe they can't do much and it just sucks. They just got to sit and wait and know a big stroke's going to come. I don't really know, but I think that's how we should think about it. All right, so someone comes in with a stroke, then they got this blood clot, we're pretty sure they got a stroke that's going on, right? It's FAST, they're having trouble moving their arm and speaking and whatnot. Shouldn't we give them TPA, tissue plasminogen activator, to go ahead and bust up the clot? No, because remember, 85% is a big number, but we still have 15% of strokes which are hemorrhagic. And this is kind of the opposite problem. Ischemic, we have a clot. Hemorrhagic is we have too much bleeding. So if someone comes in and they're having a stroke and we just give them TPA and it turns out we're wrong and they actually have a hemorrhagic stroke, we're going to make it way worse because we're preventing clotting from forming, and we need clotting to form. So the ischemic would get better in that case, and this would get much worse. So what we do is a patient comes in, we give them a quick CT, we get some lab results, and we try to, as quickly as we can, give them TPA. I think the thing is like TPA only works if you get a patient within the first 3 or 4 hours, which again, T for time. Time is very important for strokes. All right, so we did all of the ischemias. Let's now move over and look at the hemorrhagic strokes, the brain bleeds. All right, epidural is outside of the dural layer. Subdural, it's right below the dural layer. Subarachnoid, it is right below the arachnoid layer in the subarachnoid space where the CSF is. And then intracerebral is just anywhere in the brain parenchyma. It could be in a bunch of different places. All right, so let's start with the hematomas. Epidural hematoma is the rupture of the middle meningeal artery off of the maxillary artery off of the carotid. It's in the temporal bone, so it's going to be kind of like here-ish. And so when this is accumulating all of this blood, again, epidural, outside the dural layers, it cannot cross the suture line. So look at these suture lines. So if I get blood accumulating here and it's going to try to go over here, it can't cross there. You shall not pass. It cannot pass that. So it's just going to accumulate here. So as a consequence, let's say that this is a suture line and this is a suture line. You cannot cross. It can't cross there. So it's just going to start bulging out this way. And you get this little kind of lens crescent shape that forms. It's very characteristic of this crescent shaped lens, convex lens specifically. Just how do you get this? Somebody gets hit in the head, and that ruptures the meningeal artery, and you get a brain bleed. It's going to fill very quickly. because it's an artery. Arteries, you're gonna leak blood a lot more faster than a venous structure would. And also the suture containments means that it's not allowed to relieve pressure, but kind of spreading out. It's just going to kind of build and build and build in like a smaller space that's a little bit more compressed and contained. So huge amounts of pressure and very high yield as you have these lucid intervals. So very sad story is I was a kid, and I just remember walking out one morning and seeing my neighbor, some 50-year-old woman, just absolutely sobbing. And it turns out we went over, and her son, who I kind of knew, I was like 10 and he was like 20, and he was at a party and somebody hit him with a bat. And, the guy ran off, and then he went back to the party, and he kept hanging out. And then 30 minutes, an hour later, he started getting all woozy and falling over, and they took him to the hospital and did everything they could, but he died. It's just awful. But I will never forget the lucid interval, just because it was described so horribly to me. That they could have done something maybe if they got him somewhere sooner, and that they waited because they thought he was fine because of this lucid interval. Subdural hematoma. So you have these bridging veins. So they can come from the parenchyma, and I guess they can come from the subarachnoid space, but they bridge the sinus with the sort of the inner parts of the brain, the parenchyma and whatnot. So they're bridging across this dural gap. And they can cross suture lines as a result. So if you get a brain bleed, let's say a suture line is right here, that's okay, we can just go right on past it. Suture line's here, that's okay, we're going to go right on past it. And so I guess when I said crescent earlier, I shouldn't have said crescent. The other one is convex lens. This maybe is a little bit more crescent. The point is that a epidural one goes like this, while this one spreads out a lot more thin. This one, I guess, is a little bit more crescent shaped. So just very much know the shapes. You can cross the suture lines, and it is venous blood. And so it can always vary, and there are exceptions for everything, but pound for pound, all else being equal, subdermal is less acute, less pressing than they're all pressing, but less pressing than an epidural. Again, the venous, the fact that it can spread out, is not going to put as much pressure. That can be bad though, right? Because if someone gets an epidural, they kind of know what's going on right away. They come to the hospital. But in this case, people might fall, rupture one of the bridging veins, blood starts accumulating, and it might be a week, 2 weeks, 3 weeks before they start to notice symptoms and come in. And so that's obviously kind of scary. Who's this going to affect? So yeah, it can be from those mild bumps and trauma, and then it accumulates. And that's going to be because people who are elderly, you can rupture their bridging veins a little bit more easily. Alcoholics also, and the veins just become frail. And then a shaken baby. If you shake a baby, their bridging veins, I guess, are also kind of fragile, and they can tear easily as well. Cool. So about we talked about the fact that this can be over the course of a couple of weeks. So you might have this radio opaque structure here initially. So this is how you could kind of time a subdural hematoma. If it's radio opaque initially, it's kind of whitish. That means it just happened. But if it's this dark region here, it's a little bit more translucent. Then it's going to be, we can time it. Say it must have been a couple of weeks. So again, epidural is skull fracture, meningeal artery, does not cross the suture lines, do not cross go, very high amounts of pressure. Subdural is the bridging vein that goes to the sinus, and it can cross, and it's a vein, and so it's definitely a lot of pressure, but not as much pressure. It can build for weeks. Alcoholics, babies, elderly people, this is, people getting hit in the head with something like this. So, they're both usually some sort of trauma, but epidural is a little bit more clear, extreme trauma. All right, so we have these two dural layers. One of them hugs the cranium. One of them always is going to follow the brain. And we have these natural foldings. There's the brain for the cerebral hemisphere, and the cerebrum from the cerebellum. And so where this goes down, we are going to have these cerebelli, these tentorium, and we're also going to have this subarachnoid, right here, subarachnoid space here with the CSF and everything. And the point of saying all of that is that we should notice that the subarachnoid bleeds can kind of go in a little bit, unlike the epidural and the subdural ones. So It's typically going to be, I mean, it could be due to trauma, right? It could be due to trauma, and you can see here we have a little bit of blood accumulating right there. But probably more often than not than in your NBME, it's going to be due to a saccular or berry aneurysm that occurs at the circle of Willis at the branch points. So often at the ACOM, at the PCOM, or at the MCA. And so a little bit more in saccular aneurysms, they can lead to a subarachnoid hemorrhage again, so can trauma, but this is probably going to be the main one. People will complain about this is the worst headache I've ever had. This is, I don't know who the heck says I have a thunderclap headache, but that is something they might say. It's associated with African Americans, people with autosomal dominant polycystic kidney disease, people with Marfan syndrome or other connective tissue defects like Ehlers-Danlos. Because this weakens the vessels and allows for these aneurysms to form in the first place. And again, they happen at the circle of Willis, at the branch points. MCA, we know what that does. ACOM, optic chiasm, bitemporal hemianopsia. PCOM is going to be cranial nerve. So look for the down and out pupil and a pupil or down and out eye and a blown pupil because the parasympathetic Edinger-Westphal nucleus tract runs right on the periphery of cranial nerve 3. Also, if you're bleeding the subarachnoid space, that's where the CSF is. Remember, the CFF goes through the ventricular system, gets absorbed via the arachnoid granulations and the sinuses, which drain into the venous system. And so, I mean, potentially you could find it in the blood, but definitely in the CSF. If we do a lumbar puncture, we are going to maybe not definitely, but there's a high chance that we see some red blood cells. Or you might see what's called xanthochromia. And this is, I think, just bilirubin, which is kind of yellow. This is just oxidized hemoglobin. So again, this in the CSF and a lumbar puncture, you should expect to see this because this is a subarachnoid hemorrhage, which is in the CSF. So you should have some blood in the CSF. And this is just showing where we might get these saccular aneurysms. So, okay, you get a subarachnoid hemorrhage and berry aneurysm ruptures and you've been in the hospital for a couple of days, and they fix you, you're good, right? Not necessarily, right? So there's complications. We've got to monitor people who have subarachnoid hemorrhages. So a couple of reasons. There might be rebleeding. Actually, the rebleeding is kind of for this, actually. Sorry. So they might be rebleeding. And so we have a beta blocker, labetalol, and nicardipine, a calcium channel blocker. This is going to keep the pressures down so that we're less likely to rebleed. A separate thing, and I kind of organized this weird, is that when you have an aneurysm rupture, you're going to spill all of this blood and stuff over here. And all of these weird chemicals, I don't know, for whatever reason, they cause these smooth muscles to start contracting. And so you get these vasospasms. And that means that downstream of this, you're going to have ischemia. So we mentioned that hemorrhagic strokes can lead to ischemic strokes, and this is sort of why. So you might give nimodipine to prevent the vasospasms. All right, so we've talked about epidural, subdural, subarachnoid. These are all extraaxial types of hemorrhage, like outside of the brain, parenchyma. But then we have this intraaxial one, which is the intracerebral hemorrhage. And we're going to talk about this in 1 second, but I just kind of wanted to set this up as a nice parallel for what we're going to do in the next slide, which is that also extraaxial, again, same thing, subdural, subarachnoid. Here we're talking about traumatic injuries. Here we're talking about brain bleeds, and we might think, well, aren't they the same? Not necessarily, right? So for intraaxial bleed, it's an intracerebral hemorrhage, but for intraaxial traumatic injury, we have diffuse axonal injury, which is really just where the axons are going to shear. They're going to shear. So speaking about traumatic brain injuries real quick aside, like a mild one can result in a concussion, which is actually really difficult to pick up on a CT or a blood test. And I would know the term coup contre coup. So if someone smacks me right here, the whole brain, there might be a massive vac where it could just kind of slides forward and it bangs on the front part of my skull, my frontal bone. So you actually, even though I was hit in the back of the head here, I might also have my brain smack the front of my head and get an injury there. That is a coup contre coup injury. And so if you have lots of concussions over your life, lots of little tiny traumatic brain injuries, they actually kind of like build up collectively. And you can get chronic traumatic encephalopathy. You have enlarged ventricles, the protein tau, because we keep having these axonal injuries shear And we know that the tau protein is going to stabilize microtubules. Remember, it's hyperphosphorylated in something like Alzheimer's, but it's now going to leak out, and we have it accumulating in the just in surrounding tissue. People get headaches, behavioral changes, memory loss, Parkinsonism, and dementia. And this is what a brain looks like after just, boxers and football players and whatnot, just repetitive concussions again and again and again and again. Okay, so going back, so I was just doing the extraaxial, intraaxial to compare the hemorrhage to the brain injury. Back to the main plot, we're talking about strokes. So hemorrhages. What is parenchyma? Parenchyma just means what is the tissue? So, what is the parenchyma of the kidney? It's just the nephrons. Does the nephron have blood vessels? Yes, but that's not unique to the kidney, right? I'm sure there's white blood cells as well, but that is not unique to the kidney. Unique to the kidney is the tubular cells. So unique to the brain is going to be the neuron. So the inside parts. So that's just most of the brain. It's going to be intracerebral. So whenever we're talking about intracerebral hemorrhage, it is, again, remember that the intracerebral ischemic injury is going to be a lacunar stroke. Intracerebral hemorrhage is typically going to be due to, we'll talk about it. How I know that it's super crazy associated with hypertension. Both of them are actually, the lacunar and this. Now, as far as the hemorrhage, a Charcot-Bouchard microaneurysm, also associated with hypertension, is going to be found in the lenticular striate arteries, which kind of supply the basal ganglia. And it could result in a lacunar infarct, but that's kind of a different thing, actually. So that is probably going to be our main one for a intracerebral hemorrhage. But it could also be just due to amyloid deposition. And this is actually going to be a particular for lobar hemorrhage. And then we mentioned that reperfusion injury, the tissue might be weak, and if we reperfuse it, it just might be too much blood pressure. In addition to probably a lot of other things going on, just causes a hemorrhagic stroke potentially. And gosh, we're just repeating ourselves, lenticular striate, basal ganglia. Sometimes, or specifically, it could be the putamen. Okay, so brain bleeds, whether it's epidural, subdural, subarachnoid or intracerebral, is going to exert pressure, a mass effect. It is going to shift other structures in the brain and compress them in ways that they don't really want to be compressed. So a couple brain herniations to know. Remember, the cingulate gyrus is going to be I guess right now I'm pointing at the corpus callosum, but the cingulate gyrus is going to be just bordering on the cortex and the subcortical structures. So that's going to be kind of in this area. The subfalcine, so we do have the falx cerebri, which kind of goes into the page, out of the page right here. So if you know your anatomy, it makes sense that the subfalcine is going right under that, right next to the corpus callosum. And what artery is right there? The ACA is going to be supplying that particular area. And so that could lead to contralateral leg weakness. Lateral descending transtentorial herniation, better known as an uncle herniation, this is the medial temporal lobe if it's pressed inwards. And it's going to compress cranial nerve 3. It could also compress the brainstem, and if it gets the reticular activating system, that's going to be coma, or it could cause death. We also have a central descending downward herniation. Again, this could hit the reticular formation, cause a coma. It could also, you kind of need your brainstem for breathing and a lot of other things, so that could cause death. If most of these are causing death. If you rupture the basilar artery, this is called a direct hemorrhage, and you're going to be extra dead there. Cerebellar tonsillar herniation. The tonsils are going to be kind of the small inferior posterior aspect of the cerebellum. We see them in Chiari type 1 and Chiari type 2. Chiari type 2 is also the vermis, but depending on how much is being herniated, again, coma, again, death. All right, bunch of arteries. Let's go through them all. ACA, contralateral legs. MCA, think of FAST, F-A-S-T, facial droop, arms, speech, because of, maybe Broca's or Wernicke's area or something. And this can be contralateral face, arms, cortical symptoms, so aphasia. Lenticular striate, contralateral paralysis with no cortical symptoms. PCA is going to be vision with macular sparring, however many times I have to say that. Basilar and pontine is going to be the medial pons. So corticospinal goes out. Cortical bulbar goes out. Bulbar just means to the face. So you're going to get quadriplegia. if the reticular activating system is spared, then you'll be conscious. And this is called locked in syndrome, where you can't, you're aware of everything that's going on, but you just can't move really like any of your muscles, and it's horrible. AICA is lateral pontine syndrome. So remember so this is going to be the lateral pons. So what's in the pons? Rule of fours. We have cranial nerves 5, 6, 7, and 8. Specifically, the ones that are not divisible by 4 are going to be on the lateral. So especially cranial nerve 7, you're going to get this facial palsy with forehead sparing, though, right? Because forehead sparing, we have dual innervation for the temporalis on both sides. Cranial nerve 8, so you're going to have vestibular dysfunction. Maybe you're going to have hearing issues. Vertigo, ataxia, because you need the vestibular system for that. Vestibular system can also play a role in nystagmus. On the side, remember, so we have the 4 midline, like motor, nucleus in the center, and then on the lateral side, we're going to have things like sympathetic and sensory and whatnot. So here on the lateral, so sympathetic, so we get a Horner's. Cerebellum has the spinocerebellar tract, the vermis, which gets inputs from the dorsal column proprioception. That's going to be an issue causing ataxia. Similarly, we also have the flocculonodular lobe receiving the inputs from the visual system and from the vestibular system. So that also is going to contribute to vertigo and ataxia. And the nystagmus because of the visual vestibular system. Pica is actually really dang common, so much that we're going to call it the Wallenberg. And I just remember the 2 L's for medullary for Wallenberg. And now we're down to the medulla, so this is cranial nerves 9, 10, 11, and 12. We have a little bit of cranial nerve 8 sneaking its way in there. So this can cause, because it's cranial nerve 8 involved a little bit, because it's the cerebellum, again, vertigo, ataxia, nystagmus. The gag reflex has to do with cranial nerves 9 and 10. Dysphagia has to do with cranial nerve 10. The vagus nerve, recurrent laryngeal nerve, is going to come off of that and come up, and that can cause dysphagia. The sympathetic, because it's on the lateral side, is Horner's, again, cerebellum. Anterior spinal artery. So for upstream, that's going to be the medial medulla. This isn't really common, but you might see it. In the medial, we have things like the motor, M for medial, and then the medial lemniscus is also, it's right in the name. So the proprioception might be thrown off. And cranial nerve 12 is divisible by 12, so this is in the middle, and this is in the medulla, so you're going to have issues with your tongue, where, remember, lick your wound. So if it's on the left side, I guess if it's an anterior spinal, it might be both sides, but you're going to have trouble pushing your tongue out, and you might have tongue atrophy over time. Downstream, though, in the spinal cord, the anterior spinal artery, we just did this. This is really mostly just going to be maybe a little bit of corticospinal tract, so contralateral movement, but it's mostly going to be the spinothalamic tract, which is crude touch, temperature, and pain. Post-stroke pain syndrome. So if you have I think it could be a couple different things, but I think it's mostly a stroke of the PCA. PCA supplies the midbrain, and the PCA supplies the occipital lobe. Maybe a little bit of the ventral posterior aspect of the thalamus. Remember that for the thalamus, the ventral anterior goes to the motor, the ventral posterior goes to the sensory, and that also kind of lines up when we think about the precentral gyrus on the anterior side and the postcentral gyrus on the posterior side, having to do with motor and sensory, respectively. We see this trend really anywhere when we're in the head, out of the spinal cord, is that on the anterior side is motor and on the posterior side is sensory. So it kind of makes sense that this sensory issue is going to be associated with the ventral posterior. But basically, you get a stroke, and then 10% of the patients who have a PCA lesion, they're just going to have tons of random pain. And I guess that's the ventral posterior being kind of confused and just interpreting signals when there are none, or interpreting signals incorrectly, and it's just telling your brain to experience the sensation of pain. It's quite awful. So hematomas and brain bleeds are probably one of the leading causes of increased intracranial pressure. And as we said, these can lead to, this mass effect can lead to brain herniations, local neurodeficits. And if we want to reduce this pressure, we're going to want to treat this with diuretics to reduce the amount of liquid in the body, cerebrospinal fluid shunt, a lumbar puncture to relieve pressure, and you could potentially remove parts of the skull as well. when people do have elevated intracranial pressure, they're going to have papilledema. So papilledema here, we're going to see the optic disc, the radius, the margins kind of expanded and blurred a little bit. So this is going to be associated with vision issues. And the optic disc, there's actually no cones and rods there, so that's a blind spot. So you're going to have an enlarged blind spot. Elevated intracranial pressure is also going to be associated with things like headache, seizure, nausea, and vomiting. So cerebral perfusion pressure is how much pressure we need to adequately perfuse the brain. And it's going to be equal to the arterial pressure minus the intracranial pressure. So if we think about this over here, let's imagine that we have just the perfect cerebral perfusion pressure. Okay, well, then what if I then get shot and I start losing a lot of blood? My arterial pressure goes down, and it might go down enough that I cannot adequately perfuse the brain anymore. And we talked about this earlier with like watershed regions. So that's one way you could have a decrease in cerebral perfusion pressure. But another one relevant to this section is that if we have an elevated intracranial pressure, it might be difficult to adequately perfuse the brain unless there's a concomitant increase in the mean arterial pressure. Another thing to note about this is the idea of autoregulation in the brain. So let's imagine that we have the perfect cerebral perfusion pressure, but you start smoking and you're not exercising, you're eating a lot of bad food, and you're stressed, and just chronic hypertension. Your MAP just starts getting higher and higher and higher and higher. Well, if your MAP gets higher, then you know what? So is your cerebral perfusion pressure. So it's going to get higher and higher and higher and higher and higher. But why am I not getting more cerebral blood flow? Well, keep in mind, we don't want more cerebral blood flow. That would be a bad thing. But your body is going to respond by constricting these blood vessels. So yeah, we're getting a larger perfusion pressure, but because we have smaller blood vessels, less volume to allow less blood in, it actually kind of offsets the effect of increased cerebral perfusion pressure. So at the end of the day, the most important thing is we have a continuous stable blood flow, not too much, not too little, until at a certain point our blood pressure is too high and we just can't auto-regulate anymore, and then it's just going to zoom up and might even snap and pop these vessels open. On the other hand, if I get shot and I'm losing too much blood pressure, my vessels can only open so much, and my blood flow is going to go to nil. Something called Cushing reflex when we have increased intracranial pressure, and I like to think of it as like a 1, 2, 3, and then also 1, 2. They're separate. So I have a tumor, I have hemorrhage, hydrocephalus, which we'll get to, increased intracranial pressure. We just saw that if the intracranial pressure goes up, then the MAP needs to go up too. So your body is going to constrict arterial vessels and maybe dilate cerebral vessels, but let's just focus on the constricting of arterial vessels. Hypertension, the MAP is going to go up to match this increased ICP. Well, then the carotid and aortic receptors are going to tell cranial nerves 9 and 10 that, hey, like there's some weird hypertension, like maybe we shouldn't, pump so hard. And so you're going to get bradycardia. This is at least how I think of it, right? So increased intracranial pressure needs to be matched by increased MAP, so we have adequate CPP, and then the hypertension, naturally your receptors are going to respond by inducing parasympathetic stimulation of the heart to induce bradycardia. Now, as far as the irregular breathing, so this is a separate now 1 to 2, 1 to 2B. Increased intracranial pressure is going to push down on the brainstem. The brainstem has cranial nerves 9, cranial nerves 10, a lot of components that are necessary for maintaining a normal respiratory rate. So that is why the breathing gets altered. So one way you can get increased intracranial pressure, and really not a way, it's idiopathic, they're not really exactly sure how it works, is something called pseudotumor cerebri. And it's going to be a middle-aged woman, young to middle-aged. She's going to be overweight. She has a vitamin A excess, and she is taking tetracyclines, probably for acne, and for whatever reason they have increased intracranial pressure. And this is going to come with all of the things that we've associated with it. Things like nausea, vomiting, headache, right? All of those things that naturally go with increased intracranial pressure. So increased intracranial pressure, just in general how you get it, could be something like a mass, but it could also be that we're putting too much blood into the system and taking too little out, or putting too much CSF into the system or taking too much CSF out. An example is like a venous thrombosis. If someone's in a hypercoagulable state, they get a venous thrombosis, more blood is going in, they can go out, and this could lead to increased intracranial pressure. What's relevant for right now is hydrocephalus. So increased intracranial pressure because we have too much CSF in the brain. And there's kind of like 4 different ways that we can think of hydrocephalus. Non-communicating. So communicating means sharing. So this is not sharing. What does that mean, sharing? It means not sharing is it is not flowing from one ventricle to the next as it should. So this is going to be obstructive, right? It just means that, okay, here's one ventricle and here's my other ventricle, and I should just have a natural flow, but there's some big thing pressing on this that's making it difficult for the fluid to move from the first to the second. Communicating is, okay, between the ventricles, the CSF is flowing completely fine, right? It's not obstructive, but for whatever reason, it's not being properly absorbed by the veins and then exiting the head. Third is we have normal pressure. So here you have an increased CSF, but for whatever reason, your pressure is more or less the same. And this might be because of like a Boyle's law thing. So if you have like more CSF over time, the increased pressure kind of stretches out the ventricles. And if the ventricles stretch and they're squishy and compliant, this means that the pressure is going to go down a little bit. It actually turns out that the pressure might sometimes be elevated in normal pressure, but it's just kind of sporadic, and so you have to check it at the right time, which might be difficult. And then our fourth one is ex vacuo. This one's really just a phony, right? So these are just the large ventricles, but not because of extra CSF, and there's not extra pressure either. It's because of brain atrophy. It's sort of just maybe they're expanding a little bit, but it's mostly just that they look bigger relative to the fact that the rest of the cortex is getting smaller. So non-communicating obstructive hydrocephalus, it's usually congenital, something like a Chiari2. It could be Chiari1, Chiari type 2 is a little bit more significant. Dandy Walker, shown here, Chiari type 2 shown there. And this pressure in the cerebellar region is pushing on the aqueduct of Sylvius and the fourth ventricle and obstructing the flow down into the fourth ventricle and the foramen of Magendie or Luschka, the median and lateral apertures, which is then going to push it into the subarachnoid space up to the brain where it can empty into the veins. With this, you get sunset eyes. So remember that if you compress the dorsal midbrain, you get Collier sign, which is kind of the opposite of ptosis. The parasympathetic fibers going to the levator palpebrae are inhibited, and so there's this lid retraction where the lids are like super open, and then vertical gaze palsy for whatever weird reason that I don't understand. And so there's these eyes are kind of downward facing, and they're called sunset eyes. They kind of look like a little sunset. Communicating, this is non-obstructive. So why would we not be able to drain from the CSF and the subarachnoid space to the veins? Maybe we had meningitis, an infection in the meninges, and it damaged all of these structures. So it damaged the granulations, and now they just, we had a subarachnoid hemorrhage or something, and now it just doesn't drain properly. Normal pressure, so as people get older, this is actually pretty common. So this is just for whatever reason, there's an elevation in the CSF. Maybe in some old people more than others. And again, the ventricles are going to kind of expand and accommodate this so that the pressure doesn't go up that much. And if it does, it's sporadic, so it's hard to check. Technically, this is a communicating hydrocephalus. I just don't like to categorize it. And then the clinical presentation is very different than the other communicating hydrocephalus. So I just think of this as separate. This is normal pressure hydrocephalus. I think of this is for old people, and old people have trouble with the internet, like websites, like the World Wide Web, www. So this is wet. So they have bladder incontinence. Wobbly, they have this magnetic gait, you can see here. And then wacky, this might also cause dementia. So this is, again, sort of a fake. So actually we see these two things. Here's the ventricles and here's the brain. One of these, it looks like the ventricles are getting way bigger. But actually, mostly what the animation is doing here is the brain parenchyma is getting much smaller. And then it's resetting. And it's just kind of to show you that because one's getting smaller, it just makes it look like the other one's getting bigger. So people with neurodegenerative diseases, traumatic brain injuries, CTE, and schizophrenia, they're going to have extra atrophy of their brain tissue. So let's contrast this. This is someone with normal pressure hydrocephalus. So as you get older, you're going to have cortex atrophy, but maybe even a little bit more in NPH. But contrast that with someone with hydrocephalus ex vacuo, maybe with someone who has severe dementia. Notice how thin and frail the cortex is. And it just makes these ventricles look large in comparison, at least to like a normal person. And again, maybe they're getting a little bit bigger, but I would say it's mostly just that the surrounding area is degrading, and so they're just kind of like filling in that space and look bigger by contrast. Better way to think about these, in my opinion, is congenital hydrocephalus. So this is the obstructive one. This is Chiari or Dandy. Could be a tumor, and you get this Collier's sign and the sunset eyes, and just a huge increase in intracranial pressure. And then you could have acquired. Maybe you get meningitis. Maybe you have like a stroke of the subarachnoid aneurysm, and this just damages the arachnoid granulation, so you cannot drain your CSF into the veins. Also is going to increase the intracranial pressure. And then normal pressure, as the name says, does not really increase the intracranial pressure. Maybe there's a mild increase. Maybe it's fickle. It depends exactly when you measure it. And it's just from getting old for the most part. And I think of old people having trouble with the World Wide Web, wet, the urinary incontinence, wacky, dementia, and wobbly. They have this kind of magnetic gait. And ex vacuo doesn't even really belong here, in my opinion. So it just doesn't even increase the intracranial pressure. So this is our silly little segue to tumors. So TBIs, hemorrhagic strokes, and now also brain tumors can also increase intracranial pressure. So let's talk about them. Okay, moving right along to tumors. So most tumors, I mean, getting a brain tumor, getting cancer is horrible. Getting brain cancer has got to be just the worst, scariest thing. But actually, most brain tumors are benign. Really, the only malignant one you should, theoretically you should know everything, but the main one you probably need to know for the test is the glioblastoma as a malignant one. So I mean, a lot of the damage these are going to be doing is just due to increased intracranial pressure and a mass effect, right, causing like an uncal herniation or a subfalcine herniation or whatnot. But you can see with the benign, we have these well circumscribed regions, and the malignant's a little bit more chaotic, a little bit more all over the place. And yeah, this is a real son of a bitch, this section. There's a ton of tumors, and the organization is kind of confusing. And in case it wasn't clear, our grapefruit is the brain tumor. But technically, it shouldn't even be brain tumor, because we're also going to be talking about peripheral nervous system. So this just means nervous system. Let's just simplify it. All right, let's jump in. We'll break it down. So endocrine, anything hormone related, we have pineal gland tumors. Actually, one more thing I wanted to say. So yeah, we should know glioblastoma is the main malignant one. I would also know that meningioma is the most common one overall. And then pituitary tumors, specifically a prolactinoma, is also quite common. Okay, back here. So we're talking about pineal secreting melatonin, pituitary secretes a bunch of stuff, and then the cranial pharyngioma as well. So the pineal gland, remember that this sits right here, the dorsal aspect of the thalamus and hypothalamus. And if you have a swelling here, it's actually going to obstruct the dorsal midbrain. And we've already been through this. Vertical gaze, palsy, you're going to have lid retraction, which is Collier's sign. We saw these kids with these sunset eyes. And then we have this light near dissociation because the Edinger-Westphal nucleus is being compressed. So you won't restrict for light, but you will restrict for accommodation, for things getting near to your face. Randomly, it's going to secrete HCG, which can lead to precocious puberty. Pituitary. So the pituitary, very, very high yield. I've said it a million times. Here's a pituitary. It is going to, here's also a pituitary right at the optic chiasm, right at the optic chiasm, right at the optic chiasm, right at the optic chiasm. So if this starts to swell, it will compress the optic chiasm, and you will get bitemporal hemianopsia, where you lose your temporal vision on either side. Pituitary apoplexy, the tumor for whatever reason can hemorrhage. This can lead to vision loss, as you can imagine. It's right at the optic chiasm, but it's also going to increase the intracranial pressure and can cause headache and vomiting. The vision loss I'm saying is because of intracranial pressure in the optic chiasm. I hope that was clear. So 2/3 of pituitary tumors are actually functional. They're hyperfunctional. They're secreting way too much of the hormone. 1/3 of them are silent and non-functional. Lactotrophs by far is the most common one. So these are going to be prolactinomas, secreting prolactin. And I think of this as being just in adults, not kids, because adults make milk and not kids. So it's going to be excess milk production in breast tissue. And the whole, like, if a mom is breastfeeding her kid, she's lactating, just evolutionarily, if you got one kid that you're breastfeeding, you're probably not ready to get pregnant again and divert a bunch of resources and nutrients that are probably scarce. So as an evolutionary adaptation, people who are breastfeeding, the prolactin, which stimulates the breast milk, also is going to have a dual secondary effect of suppressing gonadotropin releasing hormone, so that women do not, no FSH and no LH, so there's no estrogen, so there's not a period. But if this is, we're hyper functional, we have too much of this. If we don't have estrogen is necessary to inhibit osteoclast, so you can get osteoporosis. It's not even supposed to be a thing in men, but if men have too much prolactin, I guess they can start lactating, but it's going to have the same effect on the HPA axis. It's going to suppress GnRH. It's going to lower libido and can lead to infertility. Dopamine is interestingly the prolactin inhibiting factor. So dopamine agonists like bromocriptine will be therapies for this. Somatotropes with growth hormone. If kids have too much growth hormone for a long time, they can become, gigantism. But adults have it. They're pretty much, I think their epiphyseal plates are fused, and so they're not really growing, but their hands and feet and face might fuse, might grow. So this is called acromegaly. And then corticotrophs is going to be releasing responding to cortisol releasing hormone, secreting ACTH. We have Cushing's syndrome, which is just anytime you have too much cortisol, but it's specifically Cushing disease if it comes from the pituitary gland. And, we have the stria, we have the, truncal obesity, and then the buffalo hump, and the thin skin, and the high blood sugar, and et cetera, et cetera, et cetera. Craniopharyngioma. This has to do with embryology. Anything have to do with embryology, anything with the name blast, that's going to be kid related. So Rathke's pouch, it's interesting in a very not interesting way, but you look at the anterior pituitary and the posterior pituitary, and you just assume they're just besties, identical twins for life. Turns out that the diencephalon, just basic nervous tissue, is going to make up the posterior pituitary. The anterior pituitary actually comes from oral ectoderm. That's just fun trivia that they like to ask you sometimes, but so these do have different lineages from embryological tissue, and again, anything embryological is related to kids. And it is, though, near the optic chiasm, so this could also cause bitemporal hemianopsia. So again, neurovasculature, so this is blood vessels lining the nerves. Hemangioblastoma is going to come from blood vessels, could be pericytes and endothelial cells in the brains. And we're going to see thin-walled capillaries with not a lot of brain tissue on histology. We know that EPO is, something the kidneys can secrete to stimulate blood production in the bone marrow, but it actually also is going to produce, as a couple smaller, lesser-known roles, also is going to promote angiogenesis, which would make sense if you're a cancer based off of blood vessels and you want to grow, you would like some molecule, some hormone that is going to promote blood vessel growth. So kind of makes sense that they're producing EPO. So we know that the cerebellar is highly prone to strokes, and that's because it's highly vascular and it's super large. So a combination of it being very vascular and very large just means there's a good chance that this is where your hemangioblastoma is going to appear. It appears in the cerebellum. We had the hippocampus with the cerebellum for watershed areas, but now you can also remember you can actually just think of von Hippolinda with the bell. And it's silly and that's stupid, but whatever, helps you remember it. Hematopoietic, so we can have primary central nervous system lymphoma. This is an HIV/AIDS defining brain tumor. And this single ring enhancing lesion, it's single. It looks very much like toxoplasmosis, but I always thought cats have 9 lives and this has 9 legions. So the difference is we have 1 legion over here and several legions for toxoplasmosis. Peripheral nervous system, so we have the nerve sheath tumors, but then we also have neuroblastomas, so let's get into it. Again, we see the word blast, we should think kids, and maybe embryological relevance. So remember that the adrenal medulla is derived from the peripheral nervous system, from the neural crest cells, which become part of the peripheral nervous system. I remember that is like the adrenal medulla has catecholamines. These are neurotransmitters we typically find in the nervous system. So if I have a structure outside of the nervous system, it's not really doing a good job of hiding its cover, its tracks about its ultimate origin, right? So it's we can spot, aha, you used to be a neural crest, and here's the evidence. Anything blast has these homerite rosettes, and they kind of just look like it's like a rose, and arguably they kind of look like a rose. I don't know how much I see it, but they have these things called neuropils, which are just like unmyelinated axons in the center. So if this is the adrenal medulla, so here's our, adrenal is near the renal. So here are kidneys, and then right at the top of the kidneys are the adrenal glands. So you might have a firm mass where your adrenal glands are. You could have it in other places as well, because the sympathetic chain, you could also get a neuroblastoma there. And you're going to get excess catecholamines, which is going to cause hypertension. And this hopefully should make sense, right? It's the adrenal medulla. This is making the catecholamines, which cause hypertension. So you're going to have more of that. And then these eventually are going to be, I think, monoamine oxidase and other enzymes are going to break this down into homovinylic acid and some other thing that I forget, HVA and MVA. Nerve sheath tumors, so we have schwannomas. It's going to be adults. Neurofibromas, going to be kids. The schwannoma, it's a Schwann cell origin. This wraps in the peripheral nervous system, and classically at the cerebellopontine angle. So pons, cerebellum, and here's my angle. That's my theta, right? So this is going to be near the internal acoustic meatus. So these are called acoustic neuromas, also known as vestibular schwannomas, and it's associated with neurofibromatosis type 2. One of the stains that we should keep in mind is S100, which just in general is going to be in a lot of neural crest cells. This might mimic in like the clinical symptoms, the presentation, what Wallenberg syndrome is, where we have a pica infarction in the lateral medullary, which causes hearing loss and tinnitus and balance issues and dysphagia and dysarthria. Technically, hearing loss is actually a little bit more AICA than pica, but we can ignore that. The Schwann is usually the cerebellopontine angle. You could have it in the periphery as well. Mostly it's going to be here, interacting with this. Neurofibroma. So a schwannoma is kind of like nicely circumscribed, and it's mostly just these Schwann cells over here. The neurofibroma is a hamartoma. It's a bunch of, there's a bunch of collagen, some couple Schwann cells. We got some axons, we got some mast cells, we got a bunch of random shit in here, which actually means that it's really difficult to remove these without sacrificing the underlying nerve, because it's just a bundle of stuff together, and it's hard to take out just one bit without taking about a bunch of the other stuff. Also with schwannomas, we typically just have this one big schwannoma. Here we have these several little cutaneous nodules all over the body, everywhere. Associated with neurofibromatosis type 1. So someone's born with this, and they're just going to develop more and more of these over time. They're going to get larger and larger and larger. All right, central nervous system, we made it. Looking at just neuron tumors, retinoblastoma, I think R for the retinal cells, and then B for bone. Now, in the eye specifically, if I take a photo of you, we have something called the red reflex, where the light hits your eye and it bounces off as red. You can see that picture right there. But if you have a tumor, for whatever reason, the light bounces off, interacts differently, and it bounces back as white. So you have this loss of the normal red reflex, and you get a white eye instead. So the name is leukocoria. This is the white reflex, basically. And just a quick refresher, P53 inhibits P21, P16 inhibits, the P21 and P16 are both inhibiting these cyclins. What are these cyclins trying to do? Well, retinoblastoma is normally, it's a tumor suppressor. It's inhibiting E2F. E2F, epidermal growth factor. It wants to divide. It wants to cause cancer. But luckily, we have retinoblastoma who's on our side, which is holding it down. But these CDK cyclins are all about cell growth. So they're going to go and phosphorylate this RB protein and that inhibits it. It is now turned off. E2F is free to go and cause cell division. So when you have loss of this tumor suppressor, mutation of this tumor suppressor, that is why you get this cancer. All right, CNS embryonal tumors, so medulloblastoma. So again, anytime you see blast, we're talking about embryonic and we're talking about kids. And we're going to be dealing with the homocyte rosettes. Boom, there you go, right? That's just, I think, a really helpful tip. These are classically going to be in the cerebellum near the medulla. And this can affect specifically the vermis and the spinocerebellum and like the center. And this is where we get proprioceptive inputs from the dorsal column, the medial lemniscus. So you're going to get truncal ataxia. In being in the cerebellum, right here, it can compress on the fourth ventricle, on the aqueduct of Sylvius, and this can cause an obstructive non-communicating hydrocephalus. So this increases intracranial pressure. So you can get papilledema, increased blind spots. You're going to get headaches, nausea, vomiting, and a drop metastasis. So this is a rare tumor, and it's a rare thing within this, but it can now spread downwards through the spinal cord, even going all the way to the cauda equina. So that's not really common, but that, could happen. And we see evidence of that right there. All right, so glioma. So these some of the more important ones to know. Often these are only going to be in the brainstem or in the optic region. So we have oligodendrocytes, we have the meninges, then we have the ependymal cells, and then we have the astrocytes. So oligodendrocyte, these are going to wrap multiple neurons with myelin. So one wrapping multiple neurons. I think of an egg, egg. So these are oligodendrocytes. This is our egg. There's a chicken wire capillary pattern. There's a fried egg appearance. What do I mean? This is our fried egg. This is our chicken wire. And how does that map onto this? All right, so get ready for a super awesome animation. All right, so I'm going to minimize these. I'm going to move it over there. Boom. So let's go back one. Here's our egg. Here's our chicken. And boom. That's it, right? So you can kind of see it now a little bit. Eggs are also made up of calcium carbonate, and there's going to be calcium deposits in oligodendroglioma. Meningioma, these are just the most common. They're most common. You should know they're benign. Really, the only thing that you have to think about that's not benign is the glioblastoma. So it's the most common one. Know this. It's the arachnoid layer. That kind of makes sense. Most of the other layers are just kind of like connective tissue fillers. There's actually like metabolic activity. There's stuff going on interacting with the cerebrospinal fluid. It's also got like kind of more volume than the other layers. So to me, it makes sense that this would be affecting the arachnoid layer. And it might look like an epidural hematoma, right? So you should keep in mind that meninges are on the periphery. And so that's where you should be able to quickly and immediately identify this if you're given it on the test. It's going to look different than an epidural hematoma. An epidural hematoma is quickly filling with arterial blood, and it's not allowed to cross sutures. And so you're going to get this, I think I said crescent earlier and I misspoke, you're going to get this nice lens shape to it, this convex lens shape. But here, this is just a slow-growing tumor, and it's just going to grow outward. It's going to be a little bit more spherical, so you should be able to tell them apart. You're also going to get Samoma bodies, and one of the M's here is for meninges. One of the other P's, I don't know if I mentioned that, was for prolactinoma. Ependymoma. These are the cells that are part of the choroid plexus and the ventricles. These are generating cerebrospinal fluid, and if you have a cancer here, you're going to block the natural order, the natural flow of things. You're getting an obstructive, non-communicating hydrocephalus. So every time we saw blasts, we saw rosettes. Those are homocyte rosettes with little bits of unmyelinated axons in. Here we're just going to have a rosette. So this is a rosette for the homocyte, anything blast. But here we're going to have rosettes, but they're just empty on the inside, empty lumen. All right, astrocytes. This is important. You can form a low-grade astrocyte. This is often going to be in kids, could be in adults too. But this is now it can potentially transform over to a glioblastoma. I think you could probably get a glioblastoma immediately, but I think it often goes from an innocent low-grade astrocytoma to transforms to a glioblastoma. So this is quite common. It's the most common one in kids. It's an astrocyte origin. It's low grade, so it's mostly functional, and it's still well differentiated. It looks like a normal cell. And these have this glial fibrillary, I think like acidic protein, accessory protein. I thought it might be acidic protein. Suspect. Google that. Not that it's probably that important. So This helps make a protective mesh after an injury. That is the whole point of what astrocytes do. One of the things they do is reactive gliosis, forming like scar tissues, and they use this GFAP to do that. So this is a common stain for astrocytes specifically. And if it's a common stain for astrocytes, well then yeah, it's going to be a common stain for astrocytomas because they're functional. They are still producing a lot of GFAP. Here is before an injury and here's after an injury. We have hyperplasia and hypertrophy of the glial cells, and so we're going to get a lot more green. These are going to have something called the Rosenthal fibers, which are just clumps of GFAP that we're going to see in histology. Now, astrocytoma could be pilocytic, could be giant cell, probably pilocytic. These are going to be hair-like projections. So we said that the astrocytoma can we could jump straight to, an astrocyte can become a glioblastoma, I guess, immediately, but usually it becomes an astrocytoma and progresses over time to a glioblastoma. Glioblastoma, I always thought of like, it's like a butterfly gliding. So people might call this a butterfly tumor. It kind of looks like a butterfly. I think of it more just as the fact that it's clearly not a well demarcated tumor. So that's how I know it's the malignant one. And I just remember, butterflies glide. And so that kind of looks like a butterfly. They're very high grade. They still have some GFAP, but they're very high grade, so they don't look like normal cells. But they have these, they're described as pseudopalisading cells that surround a central, necrotic core. So here's our palisading cells, here's our palisade, and here's our center. Here's our palisade, here's our central necrotic core. Okay, great. So there's our little overview. And this is the place where you might find a lot of these particular tumors. And important to know, adults versus kids. So adults produce milk. Prolactinoma is going to be adults. Hemangioblastoma, man, adult. People who have HIV are typically adults. A schwannoma, I think of like an ugly duckling. You talk about a kid who's not very attractive, and they grow up to be quite beautiful or handsome. So that's the schwann. The ugly duckling grows up to be a schwann. That's an adult. They've grown up. Oligodendrocyte, who lays eggs, adults. Meningioma, men are adults. I don't really have one for this. Memorize that. Kids need their sleep. Craniopharyngioma, cradle. Anything with blast is going to be kids. Blast is going to be kids. I just know that this is a genetic thing, so I know it's going to affect kids. You hear about kids often, something being detected, and maybe kids take lots of photos, and you're going to see the loss of the red reflex and the leukocoria. Appendimoma, so I think of like someone calling mama, and that's a little kid. And then astrocyte, I think of like Astro Boy, that's a little boy. Remember that blasts are for stem cell precursor cells, and that's also, again, kids. That's less differentiated, etc. So again, most of these, meningioma is the most common one. Glioblastoma is the most common aggressive malignant one. Prolactinomas are very common, and astrocytomas are also very common for kids, right? Astro Boy. Lung is very common. Breast cancer is very common. Colon cancer is very common. All of these metastasize to the brain. So as we went through the tumors, I sort of anachronistically referenced a few of these neurocutaneous disorders. So here they are. Emphasis on neuro has to do with the nervous system, and cutaneous, each of these is going to have something to do with the skin. And, if I could have a third feature, as we just saw, a lot of these are going to, have an increased susceptibility of developing particular type of cancer or two. So the ones, without further ado, we have Sturge-Weber, tuberous sclerosis, neurofibromatosis type 1, type 2, and then von Hippel-Lindau. Now, all of these are rare, and it seems really silly that we should have to talk about these, maybe full stop period, like that's done. But if I was trying to be generous to like the curriculum, this is 1 in 2,500, this is 1 in 40,000, 1 in 6,000, 1 in 30,000, 1 in 40,000. If you put all of this together, it's really it's a 99.93% chance that you're normal. But that means out of 10,000 people that you will see in the hospital, 7 of these are going to be affected. And I don't know how many, that means like at least once a year, you'll probably see somebody who's affected with one of these diseases. So it's worth like kind of having this in your wheelhouse. So we said nerve, skin, also cancer. All of these are autosomal dominant except for Sturge-Weber. This is a mosaic. And I remember this is like a mosaic is art, and I think of like spiders weaving their webs are like art as well. It's kind of silly. Some of these are also going to cause intellectual disabilities because, well, they have to do with the nervous system and the central nervous system. And yeah, we mentioned this. Sturge-Weber. So I thought it was funny. In Chicago, they have these potholes, and some artist is just filling them with like little mosaics of toilet paper and hand sanitizer. I thought was kind of funny. So this is somatic mosaicism. So an early mutation during embryogenesis is going to have, proliferate and have trickle down and have downstream effects where lots of these things are going to have mutations. So really early on, it's going to spread. So some of it's in the brain, some of it's in the eye, and some of it's in the skin. And that's really Sturge-Weber syndrome. You could technically have a similar mutation, but it's a little bit later, and it's then not as spread out. It's not as diffuse. So here it might just be localized to the skin. So it's possible you could have this port wine birthmark, one of the symptoms, without having the other features. Anyways, back to this. So GNAC is the gene, and this is, I'm not actually sure about the pathophysiology. It's either stabilizes or destabilizes capillary webs. The idea is that as people grow up as during embryogenesis, they either have too much or too little or too stable or too unstable capillary webs that are abnormal. And so this leads to a point wine stain on the face, just lots of these capillaries. And they can get hemangiomas and angiomas. If you get it of the meninges, this will lead to seizures, can contribute to mental retardation. And if you have it in the sclera, then this can lead to elevated intraocular pressure, which is can lead to early onset glaucoma. Here is a picture of a hemangioma, and here's a picture. Tuberous sclerosis, so you're going to get hamartomas in your skin, really. This is just a benign growth of like a mishmash of a bunch of different types of cells. You get these hypomelanotic macules. So these are not raised, these are ash sleeve spots. You get pretty much the same thing, hypomelanotic, but now these are thick, they're fibrotic, and they're elevated. That's the Sjogren patch. And this can increase the likelihood of an astrocytoma. And I just think of like tubera, like a tuba, and you need a bunch of muscle to lift a tuba. And so a couple of muscle-related tumors are going to be related to this as well. So it's going to increase the likelihood of developing those. Neurofibromatosis type 1, by far the most common. This is the one you should know the most. Also known as von Recklinghausen syndrome. So this is 17 letters, and this is on the 17th chromosome. So it causes these cutaneous neurofibromas, also hamartomas. We have Schwann cells and mast cells and collagen and axons all kind of bundled together, shown here. And you're going to have these all over the body. And someone's going to have this from birth because all of these are autosomal dominant. And so it's just going to get worse and worse and worse and worse. This might be a little hyperbolic. I don't know. Maybe there's varying expressivity. But yeah, it gets worse over time. You get these café au lait spots, really just the opposite of the ash leaf spot. These are hypermelanotic, not raised though. Lish nodules, so we see these hamartomas all the way over here, but you also can get them on your eyes. So we see them right there, we see them right there, we see them right there, we see them right there. This can, neurofibromatosis also makes you more susceptible to developing optic glioma and also pheochromocytoma. So look for elevated blood pressure as we're generating too many norepinephrine molecules. Neurofibromatosis type 2 is on chromosome 22. I just think 2 and 2. And you have 2 ears, and it affects your ears. And you have 2 eyes, it can give you cataracts. But this gives you a schwannoma. So schwannoma, acoustic neuroma, vestibular schwannoma, tomato. And this can, cause sensory neural hearing loss and cause issues with ataxia and nystagmus and vertigo as it interacts and compresses the vestibular nerve. It can also contribute to a meningioma. And again, this is the cerebellopontine angle. Von Hippel-Lindau. So okay, we did the hippo with the harp, which is supposed to be the hypoxic susceptible things, the cerebellum and the hippocampus. But then we also saw that there is a hemangioblastoma, is the cerebellum, hippo with the, so this is the hippo with the heart, but instead of the hippocampus, it's the hippo Lindau. So this is probably silly, but hopefully this helps a little bit. So we have a hippo with the bell, but you might also think of a hippo with a harp. So hippo hemangioblastoma, we already said it's the cerebellum. And again, why? Because this is really vascular and it's big, so it's likely you'll get a tumor there. Angiomatosis. So this is like a hemangioma that we saw earlier. That's a hemangioma, but there's usually just one. Here you're going to have several of these. I'm sure there's other differences. That's all I know. And then the renal cell carcinoma. So look for somebody who's maybe like peeing blood or something. And then pheochromocytoma. Again, we might have elevated blood pressure. And now all of this works by hypoxia-inducible factor. So normally the von Hippel-Lindau protein, we don't need this HAF, so it gets ubiquitinated and it gets destroyed. But if you're in a hypoxic condition, tissue's not getting enough nutrients, not getting enough blood supply, now von Hippel-Lindau lets it live, and it does what it implies, hypoxia inducible. The hypoxic environment induces it to be active, and it's going to help transcribe genes which will promote angiogenesis so that blood vessels can come towards it. We would want that during hypoxia, but we would not want that normally because that is very pro-cancer to have too much angiogenesis. So kind of makes sense then as well that it's associated with the hemangioblastoma as well. So I certainly would know that. And again, cerebellum. Okay, pivoting to headaches. So the three main headaches that you need to know, I think, for the NBME, you need to know all of them, but the three main ones are tension, migraine, and cluster. And within these, really just migraine and the tension are really the two most common ones. So that's probably where majority of the questions are going to go. Headaches typically are going to affect females more than males, except for the clusters, where it's actually going to be the reverse. Males are going to be affected a little bit more. Quick note on alcohol-induced hangovers and just general feelings of shittiness. Alcohol dehydrates you. Dehydrating you can cause a headache. You don't get good REM sleep or good stage 3, stage 4, sleep with your delta waves. So that can also make you feel shitty. A lot of GI distress, extra acid release. So the nucleus tractus solitarius from the vagus nerve is going to bring information to the CTZ, and that might make you vomit, might make you feel nauseous. Inflammation. If you get the flu, you get inflamed and you just feel shitty, right? And this is kind of the same thing. Alcohol increases systemic inflation and might contribute to you feeling shitty. Acetaldehyde is the intermediate metabolic product, and it's toxic. And so that can swim around and damage things, and might get into the area post-trema and interact and make you want to throw up, make you feel sick. And also withdrawal, right? So you're really messing with a lot of neurotransmitters when you're drinking alcohol, and your body's quickly going to adapt this like homeostasis. So the second you don't have alcohol, then your body's got to adapt again, and it might take a little bit of a lag, right? So you're drinking, you're really happy, your body adjusts for the homeostasis, you stop drinking, and then maybe you feel really shitty. All right, migraine. So again, typically this is actually great. It's often women, more often than men. There's you can sort of like feel it coming. Maybe you have certain smells, maybe you have tingling, maybe you have visions. They last a long time, hours to days. People get nauseous. Photophobia is big. Light is going to exacerbate this. Now, for the big headaches, and this is a big, bad headache, sumatriptan. I think of like sumo wrestlers to combat the big headaches. Sumatriptan is going to be abortive. Also NSAIDs and Tylenol, but NSAIDs are supposedly a little bit better. Tension headache, it's like a band distribution around the head. This is like your classic headache. It's just going to last a few hours. Clusters. So I think of like, maybe dudes are more likely to get punched in the face in like a bar fight or something, get a black eye. And so that reminds me that this is males more than females, and that it's the periorbital region, and that there is going to be lacrimation, tearing up, and rhinorrhea. So these are going to be relatively short, just 15 minutes to a few hours, but they're incredibly severe, burning, stabbing pain, again, around the eye, and you're going to have multiple episodes per day. So this is a really, really big one, and you need sumatriptan to help abort it. You also want, for people who have cluster headaches, though, preventative care is equally important, if not more important. Verapamil in providing supplementary 100% oxygen can help. Trigeminal neuralgia, so this is not one of our like mainstay of headaches, but this can cause a lot of head pain. So for certain individuals, for whatever reason, the V3 distribution, if you trigger it a little bit too much, again, this is, it's mastication, but it's also sensation. Things like just chewing gum, right? That's engaging the V3, or just shaving or just lightly touching can somehow cause these really intense shocks of pain. But so as opposed to 15 minutes to a few hours, this might just be a couple of minutes. But again, it might go a couple minutes, come back, come back, etc. Sinus. So if you have a bad immune system, if you have nasal polyps, you have asthma, you could have excess mucus production. Might also have bad drainage. So too much mucus is going to cause, might even cause more inflammation. So the inflammation plus all the mucus, all of this swelling, just is going to cause a lot of pressure and it pushes on the surrounding nerves, and that's what causes the headache. So avoid allergies. Again, NSAID's supposedly better than Tylenol, and then cleaning the nose with a saltwater solution to ease congestion apparently works. Medication, so again, NSAID's better than acetaminophen. This can work for everything except for the cluster and the trigeminal. And then the really big bad headaches, it's going to be cluster and migraine. The sumatriptans are going to help for that. I guess trigeminal is also kind of big and bad. I think of tri as in three. Tri is three, obviously, V1, V2, V3. And then C is the third letter of the alphabet. That always helped me remember that carbamazepine, an epilepsy seizure drug, is actually also used for trigeminal neuralgia. Clusters can also be prevented with verapamil and oxygen, at least fingers crossed. So the main ones, the main classic headaches, again, migraine, tension, cluster. Migraine and tension are the most common. But here's a couple non-classic ones, some of them which we've talked about. Trigeminal neuralgia, tumor can cause a headache, meningitis can cause a headache, subarachnoid hemorrhage. So, this is the worst headache in my life. This is a thunderclap headache. Also just drinking too much, obviously. So that literally could be a question, right? Somebody comes in and they got a big headache and you're trying to figure out what it is. Don't overlook the obvious. They might just be like fucking hungover. Seizures have to do with unregulated, sort of like electrical storms spreading throughout the brain, sort of like wildfire. There's often going to be involuntary contraction and or relaxation of the muscles. Now, these can last from a few seconds to a few minutes. Now, if you have seizures that last for longer than a few minutes, or you have a seizure, you stand up, you feel better, and then 30 minutes later you have another seizure, and then you get better, and then 30 minutes you have another seizure, that is status epilepticus. Not to be confused with epilepsy, which is where just throughout your life you happen to have seizures, right? This is long seizures or back-to-back seizures within like one day, one episode. People often lose consciousness. Often there's urinary incontinence, drooling, frothing of the mouth. People might bite their tongues. There's post-ictal confusion. So you can distinguish this from vasovagal cardiac syncope, where people might pass out. But people normally, if they pass out from cardiac syncope, they get up and they're fine. Here, they're really confused, and maybe for a couple minutes, maybe even a couple hours. And some people have an aura, right? It's kind of like a premonition. They can, sort of like a migraine, you can sense or smell or see little flashes. You can tell that it's coming. And if they can't tell it's coming, then they can maybe prepare, right? Sit down, lay down so they don't fall and hit their head or something like that. We said a lot of times it's just neuronal activity that's spreading uncontrollably. It is, but sometimes it also has to do with like there's one focal part of the brain that has become like I don't know, not self-aware, but it's engaging in this like autonomous firing, and just there's this synchronously firing again and again and again. So like a little circuit, right? So it's constantly firing, and it's constantly firing, and it's constantly firing, and they can fire out to other things. So here again, we have this focal point, and then it's causing other areas of the brain to fire as well. Or generally, though, people who are going to be prone to seizures or epilepsy, again, we have firing of neurons when we shouldn't. So what might lead to that? Lowering of the threshold potential from like -70 to -60, so it's easier for them to fire. excuse me, sorry, lowering the threshold potential. So instead of negative 55, it's like negative 65. So we only have to go from negative 70 to negative 65. What I was saying earlier is you could raise the resting potential alternatively from like negative 70 to negative 55. So I just have to go from negative 60. So I go from negative 60 to negative 55. We could, GABA is an inhibitory neuron. If we have less of that, we're going to have more firing. If I have more glutamate, which is the main excitatory neurotransmitter of the brain, I'm going to have more firing. Hyperpolarization also creates a refractory period for neurons. And so if we have less of that for whatever reason, there also could be, this could lead to seizures. So as we mentioned, not to be confused with status epilepticus, if you just have like 2 or more seizures, really low threshold in your life, but they're just there at different times, and they're unprovoked. That's important. Unprovoked meaning that there's just kind of random, unpredictable, no clear attributable cause. Then you are said to have epilepsy. Causes, which we'll get into, are going to be things like infection, certain metabolic levels, for glucose and sodium and whatnot, traumatic brain injury, strokes. But for epilepsy in general, there are a lot of genes that are found which somehow have a link to them. Okay, so wait, when we're pausing here, I'm going to go back to the previous slide. The previous slide, the sound is on and I can't turn the sound off. So the previous slide is showing different causes of seizures, and it's going to change from one group, one age group to another. But for adults, trauma is a big one. So let's go ahead and look at this cause of trauma. In the head, Breaking Bad, Sopranos.
What the hell? What's wrong with him?
Chrissy, he's fucked up.
What's the matter with you?
Don't they have medicine they're supposed to take, these assholes?
I don't know.
All right, so you guys get it. So, trauma, adults or older people falling. If you hit your head, this could, you're spilling a lot of cellular contents into the interstitial space and breaking up the tissue is going to free up a lot of chemicals, which can somehow, as we said, lower the threshold potential or raise the resting potential or whatever needs to be to happen to cause a stroke as possible. Brain tumors also could cause strokes. For kids, it's mostly going to be things like meningitis and infections. For really old people, it's probably going to be things like stroke. And again, the hypoxia can change the extracellular and intracellular environments to make it easier for whichever mechanism to cause firing to occur, cause a seizure. Metabolic reasons as well. So if someone's blood sugar is too high or too low, that can cause it. If blood sodium is too high or too low, that can cause it. And eclampsia, you have low magnesium. And that's actually one of the treatments for someone with eclampsia, pre-eclampsia, is you give magnesium. They noticed for a long time some women just have seizures when they're giving birth, and they call that eclampsia. And then they noticed that actually, when they got more sophisticated medical technology, they realized, they also have high blood pressure, that predates that, and they call that preeclampsia. But it's really the high blood pressure which somehow relates to the seizures. But again, it's just they discovered the seizures, the eclampsia first. And drugs as well can cause seizures. And again, these are non-epileptic seizures. Epileptic seizures we're not really sure why they happen or what the rhyme and reason is. As we said, there's just a lot of random gene mutations linked to them. So typically, though, we just don't even know, right? Not even talking about epilepsy. Someone has a seizure, we just don't know what causes it most of the time. So we have focal, which is just one small part, or we have generalized, which is the whole brain. Often the focal part will spread and will eventually, consume the whole brain. So small part of the brain, we can have simple, you maintain consciousness. Complex, you lose consciousness. General is going to be the entire brain. So the most common type of generalized seizure is the tonic-clonic grand mal. Now, this can happen just on its own. You can go straight from being fine to a tonic-clonic grand mal seizure. But more often than not, it's actually going to start as a focal one and then move over to a tonic-clonic grand mal seizure. So we have tonic seizures. Tonic just means like a tonicity, just the muscles are like flexing, they're active. Often it's going to be the extensors and again, stiff muscles. I think of a stiff tonic drink that you might get at the bar. Myoclonic, or sometimes just called clonic, is just this alternating like rhythmic contraction and relaxation. Maybe not super rhythmic, so just alternating contraction and relaxation. You're going to get this jerking motion, this clonic shown here. And so the tonic-clonic is just starts off with a tonic and then it goes to a clonic. Atonic is just no tone at all. Just all your muscles go completely limp and you're just going to fall to the floor. And an absence seizure, also called a petit mal, is often going to be with kids, and you just have this you just lose consciousness. So generalized seizures are typically going to be complex in the sense that we're impairing consciousness. So kids just kind of totally spacing out, and there's typically not a post-ictal confusion though. And I think there's one more thing I wanted to say, but I can't think of it right now. All right, partial seizures. So localized one part of the brain. Typically, it's going to be the medial temporal lobe. Remember, this is like the uncus from the uncal herniation. As we said, simple, you maintain consciousness. Complex, you lose it. Something called the Jacksonian march. So if I'm noticing my fingers are shaking because I'm having a little seizure, and then the shaking moves from my fingers to my wrist to my forearm to my arm to my shoulder. That's a Jacksonian march. And as we said, they often go to the secondary generalized seizures, specifically the grand mal. So the absence, we said, is petite for kids. You get this kind of like blank stare. And if you do an EEG, you'll see a 3 hertz frequency spike. There's a type of epilepsy that kids have where they just have, repetitive, frequent, reoccurring absence seizures throughout their childhood. It's called juvenile absence epilepsy. Atonic, muscles go completely limp. Often you'll fall to the floor. We'll have kids or adults, have to wear a helmet just sometimes in case they're just walking and they just fall because you can really hurt your head. Tonic, the muscles go completely stiff, often with the extensors, it could be flexion, but it's often extension. Think of a stiff drink. A tonic. Myoclonic, you get these alternating jerks. Juvenile myoclonic epilepsy is kind of like the juvenile absence epilepsy, where just kids have this repetitive myoclonic seizures throughout their childhood. Often it's if they don't get enough sleep, they can actually have this. And then the most common one, again, most common on its own and most common because often the primary seizures are going to generalize to it, is the grand mal, where we first have the tonic and then we have the jerking myoclonic. And so when people talk about the aura, a lot of times the aura that somebody experiences is actually the fact that they had a simple partial seizure that hasn't really hit consciousness yet. And, maybe it's right on the border, right? And they just know something's wrong. It's the fact that they're having a seizure, but they can't tell yet. But then when it transitions over to the generalized seizure, then it's clear that they're having a seizure. So it's right on the border of consciousness, the simple, and then it goes to the secondary. And there's going to be very, very severe post-ictal confusion. Let's watch this, actually. This is a pretty good video showing what a grand mal seizure looks like. They're going to show the tonic first. So here's just a myoclonic, just on its own. You can see the rhythmic contraction. And let's wait for this to restart. Seizure stops. Here we go. Boom. Seizure starts, tonic. Notice those extensors. Now he's doing the rhythmic contraction, the clonic. So as we said, the complex partial seizures are quite common. Generalized tonic-clonic grand mal seizures are relatively common. And then the complex partial seizures often secondary generalized to tonic-clonic grand mal. So grand mal on its own or grand mal from a complex partial conversion or just the complex partial. These are going to be the most common ones. Neurodegenerative disorders. I find it interesting. Now we have protein accumulation and deposition causing pathologies elsewhere in the body, but for whatever reason in the brain, protein accumulation is a particularly big problem. Things like Alzheimer's, Huntington's, Creutzfeldt-Jakob disease. I don't know what it is about the architecture of the brain, but it's just really susceptible to protein aggregates. Just an interesting thing to know. Obviously, we're talking about the brain, so if you damage the brain, we're going to get dementia in a lot of these diseases. So this is specifically a reduction of cognitive abilities and or memory, perhaps behavioral changes. Neurodegenerative disorders also might cause movement defects. So I will say that neurodegenerative disorders will either cause dementia, movement defects, or both. Typically, we're going to see shrinkage of the brain, the cortex, and this can result in ventricular enlargement, just relatively speaking, and this is known as ex vacuo. Now, the types we're going to be going through are Alzheimer's, by far the most important one to know. It's the most common. Even in developing countries, it's the most common. Parkinson's is the second most common, and it's the most common neurodegenerative disorder is causing movement defects. Lewy body dementia in many ways mimics Parkinson's, but it kind of has like a reverse timeline in terms of the pathological progression. Vascular dementia is relatively common, and then a couple of the less common ones, but ones you have to know, frontotemporal dementia, Huntington's, Creutzfeldt-Jakob disease is very famous but very rare. And then multiple sclerosis is quite common, and this is arguably a neurodegenerative disorder and arguably a demyelinating disorder. So Alzheimer's, far and away the most common. Cerebrovascular, so people just getting like these little mini strokes that each time you have the stroke, you have a little bit of a decrease in your mental cognitive capabilities, and then you're fine, and then it gets a little bit worse. You have another stroke, fine, a little bit worse, etc. Alzheimer's. Okay, most common, profound memory loss, so it's especially going to affect the hippocampus, language issues as well. The pathophysiology, so we have this transmembrane amyloid precursor protein. And now this could be cleaved by the beta, or it could be cleaved by the alpha. It's cleaved by the alpha, you're totally fine, no problem there. But if it's cleaved by the beta, it can be cleaved by the beta, and then the beta actually gets cleaved by something called the gamma. But again, we started with the beta pathway, hence the name. Now these beta amyloid plaques, beta because they went the beta rather than the alpha secretase pathway, can start accumulating, aggregating. I think specifically the beta sheets start stacking together, and they form these large extracellular aggregates, which we can see here, and this is bad for the brain. This can weaken the vasculature. This can lead to intracranial hemorrhages, which we talked about earlier, especially lobar hemorrhages. So bleeding contained to like the frontal lobe, or separately bleeding contained to the parietal lobe. Additionally, we should talk about this here, the tau protein, which stabilizes microtubules. This can be hyperphosphorylated. This causes it to leave the microtubules. They're now destabilized. They fall apart, and you start to get these tau protein aggregates. These are going to be intracellular. We can kind of see these here. We're going to have a similar thing with frontotemporal disease, but the tau protein it's going to be a little bit different. Remember, we also have tau proteins for people who have repetitive chronic concussions and develop CTE. As far as the genetic predisposition, well, remember that APP starts off the beta amyloid plaque. What chromosome is that on? That's on the 21st chromosome. So if you have Down syndrome, you have 50% more APP. This is going to lead to extra amyloid deposition. And I think it's like, I'm making this up, but it's close-ish. Like 50% of like people with Down syndrome by, I think, the time if they reach 40 or 50 are going to start to show signs of Alzheimer's. The apolipoproteins, there's actually two different alleles. The ApoE2, this is protective. So I couldn't think of a way to memorize this, and I asked my girlfriend, and without really hesitating, it's kind of funny how our brain works. She said, "Oh, the North remembers," like a Game of Thrones thing. The North, that's two words, remembers. So the North remembers ApoE2, you will have a better memory. You're less likely to get Alzheimer's. ApoE4, this one's easier, you forget. This is going to be the bad allele. Presenilin, it's actually in the name. Presenility, this is also another early onset Alzheimer's disease. You should be able to notice the beta plaques and the tau proteins as well on a histology finding. As with most of these neurodegenerative disorders, you're going to have shrinkage of the brain, especially the cortex, and especially the hippocampus. Again, memory is going to be a thing. And for whatever reason, low acetylcholine is a finding and something you should know about. Some of the medications are going to try to raise acetylcholine levels. Parkinson's. So the second most common degenerative disorder, the most common one that leads to movement. And this is going to be a loss of dopaminergic neurons in the substantia nigra. Remember that this is the two-faced organ of the brain. There is the pars reticulata, which retards movement. It's part of the inhibition with the GPI of the thalamus. But then we have the substantia nigra compacta. And I think of compacta with D. CD, like a compact disc, has the dopamine. And substantia nigra is the black substance, and that's because tyrosine becomes neuromelanin, which it can also become dopamine as an alternative thing. So it starts with alpha-synuclein regulating the stability of these vesicles in the presynaptic terminal of these neurons. This is going to stabilize them, and it regulates the release of dopamine. So if you have an issue with the alpha-synuclein, one, they're going to start to aggregate. They aggregate and they form what's called a Lewy body. This is intracellular. Kind of see these here, even though this is just an illustration. The dopamine also is not properly maintained in the vesicles. It's going to spill out and causes oxidative damage, which is going to lead to the death of the cell. There is some opioid drug that they made in the 70s and 80s, and I guess when they manufacture it, commonly you get a very toxic byproduct called MPTP, which can I think recreate permanent Parkinsonian effects within just a couple of days. So this is really bad. The clinical presentation, traps. So people are going to have a tremor. Specifically, it's going to be a resting tremor. So if you start moving your hand to grab a cup of coffee or something, your tremor is actually going to get better. So when you're just sitting still is when it gets the worst. Sometimes it's called pill rolling. It looks kind of like you're trying to roll like an Advil pill or something between your pointer and thumb finger. Rigidity. So actually, let's start with this right here. So the tremor is actually difficult to explain. I looked up a paper and it went over my head. Why we get the tremor, but the hypokinesia, akinesia should make sense. We're destroying the substantia nigra pars compacta. Remember that this activates the direct pathway and inhibits the indirect pathway. So both of those effects are going to be pro-movement. So if we get rid of this, if we have destruction of the substantia nigra pars compacta, we're going to have less movement, hence hypokinesia and akinesia. So this postural instability, you have trouble stabilizing your back muscles and walking, shuffling gait, you have a hard time moving your legs. So you get this very, very specific walking gait. And this is going to lead to rigidity. So these are going to be upper motor neuron signs because this is in the brain. And they call this a clasp knife. And you see how a knife slowly opens, slow, fast. Same thing here. This is a clasp knife. Look at this. So it's resistance, then it goes. So again, that should make sense. The tremors, you kind of just have to memorize. That one's a little bit weird. You also get REM sleep behavior disorder. That is something quite noteworthy. So they're going to have issues sleeping, and then the REM sleep is going to be disturbed. And ultimately, so the movement disorder comes first. Eventually, you can get cognitive issues with Parkinsonism. Now, this is really the flip, the inverse of Lewy body dementia, right? So with Parkinsonism, we're going to have these dopaminergic neurons in the substantia nigra being destroyed, and then we're going to get more and more and more over time. And eventually, across time, we might start getting them in the cortex, and that's what leads to dementia. This is the opposite in many ways. So we're going to start with these Lewy bodies that are going to be formed in the cortex, more in the cortex, and then eventually it might make its way to the brainstem or the basal ganglia or whatnot, leading to movement disorders. So if you have cognitive issues first, or at approximately the same time, it depends, that is going to be Lewy body dementia rather than Parkinsonism. It's often misdiagnosed. And I guess it's just difficult to get brain biopsy to find these Lewy bodies. I think Robin Williams' wife, after he died, wrote an article saying that he had Lewy body dementia, and that's what led to his suicide. I don't really know about that, but I think for a lot of these diseases, it might be nice to put a celebrity name or face just to help you remember. And I don't know if you ever have to describe it to patients or I don't know what the real utility is, but that's why I'm doing this. Hallucinations are especially common here. All right, so Huntington's. We have this Huntington protein, which is a normal protein, but we get this CAG repeat. So everyone's going to have a repeat. Most people are going to be 6 to 35. And if you get more than 36, then technically that's the cutoff where we now say you have Huntington's. The more repeats you have, the worse the disease is. It's going to correlate here. And the more you have, it's also going to correlate with an earlier onset. So more repeats, it's going to hit you earlier and it's going to be worse. And there's something called anticipation, where every generation, so grandparent to parent to kid, the age of onset, in other words, the disease phenotype, in other words, the number, you're going to get more repeats as the generations increase. So that means earlier onset and worse phenotype. So these CAG repeats, it makes a polyglutamine structure. And I guess this causes the proteins to aggregate and cause mischief. And this can destroy lots of parts of the brains, especially the striatum, with an emphasis on the indirect pathway, which is why you get these hyperkinetic movements. Also associated with Huntington's is the NMDA receptor. It's overactive and you have too many of them, and so glutamate's going to rush into the cell, which causes calcium to rush in the cell, and so this excitotoxicity can cause apoptosis, which causes death of the cell. So chorea, this hyperkinetic sort of dancing movement, it's hence the name chorea, also emotional and behavioral changes as well. So as we mentioned, a little bit of calcium in is normal with the NMDA receptors for glutamate, but you have more of this with the Huntington disease. Vascular dementia, so also known as multi-infarct dementia. So you're getting lots of little mini recurrent strokes. This is progressively going to be damaging the brain, making it worse and worse and worse and worse over time. And it's going to be the usual suspects: cardiac arrhythmias, chronic hypertension, obesity, smoking is obviously a big one, which are going to make you more susceptible to these mini stroke episodes. Remember that this is the second leading cause of dementia after Alzheimer's. Frontotemporal disease, so it's in the name. The frontal lobe can cause aphasia and issues with judgment. The temporal lobe, we see this with Kluver-Bucy syndrome, where it causes these extreme personality changes. I don't know if you necessarily get the hyperorality and hypersexuality that you have here, like what you would have with an HSV infection, but definitely personality changes and lack of empathy are going to be quite big. We like Alzheimer's, we have these hyperphosphorylated tau proteins, but they're round. They're called PIC bodies because this is also known as PIC disease. They're round here rather than being tangles. So we have these little tangles here in the Alzheimer's, and here they're just going to be round. You also have a hyperphosphorylation, hyperubiquitination of TDP-43, which is a transcription factor suppressor is one of its roles, but another one of its roles is that it helps with double-strand break repair. So this protein is not able to work the way that we need it to. Creutzfeldt-Jakob disease. So this is going to be a super rapid progression. So within maybe a year of diagnosis, someone's going to die. And that's because we're going to have this amplification of proteins, which we'll talk about. Startle myoclonus. So if you spook them, if you come up and tap them on the shoulder when they're not expecting it, they might just go right into myoclonus, this rhythmic contraction, relaxation, contraction of muscles. EEG will have really sharp waves. You might find 14-3-3 proteins in the CSF. If you do a histological, do a biopsy, look at the histology, you're going to see all of these little vacuoles. They look like, looks like a little sponge under the microscope. So they call it a spongiform cortex. And the way this works is we have a normal protein. It can ultimately eventually be converted into the prion zombie version of the protein, the SC. So prions are very stable proteins. They cannot be damaged by proteases. Normal sterilization techniques like UV or boiling or whatever probably aren't going to destroy them. They're very stable, and they have the added benefit of converting the normal copy of the protein into the zombie copy of the protein. So here's a normal protein, here's the prion protein, and now we have two prion proteins. And it's kind of like a party, right? I invite two friends, they invite two friends, they invite two friends, they invite two friends. Eventually you have this amplification where 1,000 kids show up at your house. Same thing here. One prion protein makes 2, makes 4, makes 8, makes 16, etc. That's why it's going to get you so quickly. All right, so this is a very famous disease. It's very rare, though. And especially what this is most known for is like mad cow disease. This is probably, if you ask somebody about, like, if anybody has heard about it, this is probably where they've heard about it. And I'm just going to go ahead and say, so already this is, of all of this is quite rare. But even here, it's even more rare. Look at this tiny, you can't even see this little sliver, this 0.1%. This is variant Creutzfeldt-Jakob disease, the mad cow disease. So we got this from cows. So in the UK, a lot of cows were infected with this, and I guess they were feeding cows to other cows to save money. And there was a big spike, and 4,000 people, I guess, or so got this at the peak and died. So the cows had bovine spongiform encephalopathy, known as mad cow disease, and people would have a nice steak. And again, you cook the steak, you're normally going to kill the bacteria, but the heat does not denature these prion proteins. They're quite stable, so they get into your body, into your brain, and they can cause a problem for you. We saw a similar thing with Kuru, with this ritualistic cannibalism for certain New Guinea tribes. And again, these are famous cases, but they're 0.1% of all of the cases that we'll see. So maybe they were more common back in the 90s, at least the mad cow disease, but nobody's really getting mad cow disease so much anymore. Iatrogenic, so they used to do like surgery on people, and brain surgery, and whatever, somebody's fine, and then of course you sterilize the tools, and then later, a couple weeks later, you got to do another surgery. You use the same tools, they've been sterilized. But remember, the sterilization, the UV, the boiling does not necessarily kill the prions. So we're actually giving prions from patient number 1 to patient number 2. So that's iatrogenic. Some people have just a genetic predisposition, so that whatever, in the 30s, 40s, 50s, 60s, they're more susceptible to have the protein just naturally accidentally fold into a prion, and then of course it's going to have this zombie amplification of the other proteins. And then the sporadic is actually the most common. It's just, we don't really know why, just some people as you get old, I guess it's just a numbers game, right? You play the lottery enough times, you might win. You got enough proteins in your brain over the course of an 80-year life, just by odds, one of them might flip into a zombie protein, and boom, there you go. That's the end of that. SC is known as scrapie. So we see this, it's in humans, it's in cows. It's also in sheep and other animals as well. Related disease, it affects the brain, prion proteins. But they call it scrapie because it makes them itch, like very itchy. And so they would see these sheep just like kind of crazy, and they're just itching themselves so much that they're losing a lot of their wool. And so they're scraping themselves against the walls, and hence the name, the scrapie protein. All right, multiple sclerosis is arguably a neurodegenerative disorder, but it is demyelinating, so we're going to put it more in, categorize it in this group over here. So now we're going to start with the demyelinating disorder. So multiple sclerosis, by far the most important one to know. Osmotic demyelination, also known as central pontine myelinolysis. I think both of these names are good to know. They're a little bit telling. And I think I really goofed up and I forgot to write the rest of them. Guillain-Barre is going to be one. Progressive multifocal leukoencephalopathy, Charcot-Marie Tooth, Crab disease, adrenoleukodystrophy, et cetera, et cetera. There's going to be a lot of them. We are destroying the myelin, and that's going to affect nerve conduction along the axon. Multiple sclerosis is the most important one to know. So demyelinating the central nervous system and the oligodendrocytes, the myelin there. So the relapsing remitting multiple sclerosis is the most common form. We can see that over here. It's a little bit like we said, if you imagine earlier we were going down, but now let's go up. If you're showing this dementia severity with the vascular dementia, we said it's going to go up. You have a little stroke, then it's here, and then it goes up and here. It's very similar to this, is that it just gets progressively worse in a step-by-step manner. Maybe the difference is it'll get worse, and it gets a little bit better, but it never goes back to the baseline. So you're always a little bit worse than you started off. And then you have another episode and it gets way worse and a little better, but never back to normal. And so again, you're going to have this progressive stepwise progression of the disease. There's other kinds, but this is the most common one. It's going to affect heavily myelinated areas, obviously more than other ones, which are things like, and that actually is to say for all of these diseases, but optic nerve is particularly myelinated. And so this can cause optic neuritis, so you might just have trouble seeing. And it's not binary, right? It's not like you can see or you can't see. There's a degree, it's a spectrum. So Marcus gun pupil, better known as the relative afferent pupillary defects, it really says a lot about it, right? So the R is underscored because it's really important here. If you shine the light into the right eye, the eye that has like a demyelination issue, and also this is only this is typically if it's going to be one side more than the other side, but I suppose it could do both. But let's say I shine light in your right eye. Let's say your optic nerve is working 50%. Well, if you keep the light shining in that eye, it'll eventually constrict. It just might be a little bit slower than it would otherwise be. Okay, well, let's say you now have it just in the left eye. Both pupils are constricting. We have direct and consensual pupillary response. And then I swing the flashlight over to the right eye. The right eye doesn't work as well as the left eye. And so your pupils actually might dilate for a second before the signal picks up and then it goes ahead and constricts again. So we can kind of see that here and here. Let's actually look at this one. So I think, all right, pupils constrict. Notice how the pupils got bigger. So this is the eye that's bad. The pupils got, if you shine it, it's going to constrict right there. But it's only when you swing the flashlight, you can see it. One more time, they constrict, and then it goes up a little bit, right? That's how you tell this. That's really, I think, important to know. The cerebellum and the brainstem, a lot of myelination there. This is just going to lead to ataxia. Other things, but especially ataxia. The medial longitudinal fasciculus, which is in the midline of the brainstem and the pons. This can lead to internuclear ophthalmoplegia, and that's a lot there. But remember, internuclear, it's between the nuclei, the abducens nuclei and the oculomotor nuclei via the MLF, which is going contralaterally. And so what you're going to have is a lateral gaze palsy. So the left frontal eye field will go to the right PPRF, which goes to the right abducens nerve, which abducts the right eye laterally. The left eye should look medially, but it can't because the MLF isn't working. Neurogenic bladder, so let's say you go to pee, signals are going to be sent between your bladder and your brain saying, hey, you can stop peeing, we've fully evacuated our bladder. But if you have MS, that communication's not quite there. So your brain doesn't know when you're done, like that you fully peed. So it says, okay, we're done peeing, but there's still some urine there. And so it's 45 minutes later, you have anything to drink, but then you got to go pee again. So someone's going to have to pee a lot, and probably not a lot's going to come out. Typically affects women in their 20s and 30s. And so I think I said this earlier, but that was funny. I was using my girlfriend's computer when I first found this picture. I Googled a young woman, has to pee, and this came up. And somehow she saw that on her Google search, and I think she gave me the benefit of the doubt, but it was just kind of an awkward thing to assure her that this was for a lecture. Uthoff sign. So if warm weather, just warm temperatures are going to slow nerve conduction. And we're affecting the myelin, which is, trying to, accelerate nerve conduction. So MF have slower conduction. If they take a hot bath, it's going to be even slower conduction. So whatever symptoms you have will be exacerbated in heat. And they actually used to use hot baths to diagnose MS. But they used to diagnose it that way, but it very well still might come up in a vignette. Lermit sign. So if you flex your neck, remember flexion is typically if you're going to make the angle here smaller. Flex your neck forwards, you have an electrical shock that kind of goes down your spine. To diagnose this, you have Lermit sign, you have Uthoff sign, or a young woman in the 20s and 30s with vision and bladder issues. Yes, but a little bit more quantitatively, we can do a lumbar puncture and look at the CSF. Do we see antibodies in the CSF? Do we see myelin that's been attacked and ripped off of the axon sheath? And then we might have periventricular plaques if we do an MRI of the brain. Osmotic has to do with salt. Demyelination is we're getting rid of the myelin. And then it's also known as central pontine myelinolysis, destruction of the myelin. So it's the central pontine area, which remember is supplied to the basilar artery and the in the pontine artery. So the central pons, and we should know all of the cranial nerves and whatnot there, etc. And so the osmotic aspect, this is if someone comes in, they're hyponatremic. We either raise their sodium, we get an intern or a med student, maybe a med student wouldn't be doing this. So a resident comes in, raises the sodium too high or too quickly, and for whatever reason, that damages this particular area, causes demyelination. And so this is, it's mimicking of it's the central pontine, it's the basilar area, so it's going to mimic locked-in syndrome because we have the corticospinal and corticobulbar. Remember, bulb is for the face, so you can't move your arms or legs, you can't move your face. You have something called locked-in syndrome. There's a horribly sad case about someone named Tony Nicholson in the UK who was just this successful business person, played rugby, and then he just had a really, I think he actually had a basilar stroke. But again, it's the same presentation. For 7 years, he tried to find some sort of meaning in life as someone with locked-in syndrome, and it was just so miserable that he wanted to end his life. But being paralyzed, he couldn't do it without assistance, and it was illegal in the UK. And there was this big legal battle, and he lost. And he was so distraught. This is just the saddest picture to me. I mean, to me it's amazing. He can't really control his face, and yet somehow it still gets through just this immense, overwhelming. Depiction of sadness, right? It somehow still gets through in ways that I don't really understand, and he just refused food for a week and he died. It's awful. Guillain-Barré syndrome. So this is going to be molecular mimicry. So look for a patient who they're like, I had an infection 3 weeks ago, and now I'm having trouble feeling my toes or something, or having trouble breathing. So You get an infection. Often it could be virus, could be bacteria. Often it's going to be Campylobacter jejuni. Peripheral nerve demyelination. Notice that the peripheral nerves actually include cranial nerves 3 to 12. Is going to be symmetrical. So it's important that it's symmetrical ascending paralysis. So you're going to have diminished deep tendon reflexes. So again, this is things like Achilles, Babinski, patellar reflex. And ultimately the concern is that it might get to the diaphragm and limit breathing. So a respiratory workup initially is needed and you might need respiratory support. Most people though, eventually it'll go away. You'll recover, like 80% of people, but 20% of people are going to have like long-term symptoms, varying degrees. Acute disseminated encephalomyelitis, also known as post-infection. So after an infection or vaccination, the vaccination is more rare. Some people can get acute MS symptoms. Now, this does affect kids, which is how, MS is going to be women in their 20s and 30s often. It could be men, but more often than not, it's going to be women in their 20s and 30s. This is going to be kids. It's a one-off thing, right? MS is progressive. But this is just, you get one big episode of demyelination. And you can see that here. I mean, look at all of these little demyelination and all over the brain. And it's acute. It's one time, but it's very severe, and 10% of people die. And I'm sure the people who don't die, they're going to have long-standing effects. Progressive multifocal leukoencephalopathy is an AIDS-defining illness. So the JC virus gets reactivated, and it destroys oligodendrocytes. So it's going to have a lot of like MS-esque symptoms. It's rapidly progressive and fatal. Charcot-Marie tooth. So this is a genetic disorder where people have a defect in CMT1 or CMT2. CMT1 is a myelin protein. CMT2 is an axon. Either way, we're going to affect the peripheral nerves in the upper and lower extremities, a little bit more in the lower extremities. So this is going to be motor and sensory. And it's just progressive. It just, as someone gets older and older, the symptoms will become clearer and clearer. And they're like Friedreich ataxia, they're going to have this pes cavus, this high arch. Krabbe disease, metachromatic leukodystrophy, adrenal leukodystrophy. You might recall these from biochem. These are going to be storage disorders or really destruction disorders. So a lysosomal storage disorder is we send something to lysosome, we want it to be broken down, but if we're missing a particular enzyme, we can't break down these sphingolipids. So Krabbe and metachromatic are both going to be here. Sphingolipids and cerebrosides will accumulate. And you're going to get all sorts of CNS and a little bit of PNS issues. In the peroxisome, we do a little bit of beta oxidation for very long chain fatty acids. Normally do mitochondria, but very long is in the peroxisome. And this is adrenoleukodystrophy. This does affect the central nervous system, but the adreno aspect tells me that the adrenal crisis, the adrenal glands are going to be particularly affected. And that's actually the larger issue here, is that the adrenal glands are not working or they're working too much, or in any case, epinephrine or norepinephrine is getting spilled in the blood. And you can hypertensive crisis. Sorry, I got a phone call that interrupted the recording. The dogs also get retinitis pigmentosum. What we noticed with her was that she started bumping into things specifically and only at night, and she had a hard time finding the tennis ball if it wasn't right in front of her face. And that actually perfectly matches up with the clinical presentation for retinitis pigmentosum. You lose the peripheral vision, but the central vision is fine. And because of loss of rods, which are easily activated by just a tiny amount of light, you really can't see at night. So we got to have all the lights on, and you got to put the ball right in front of her face, and she can actually see completely fine if you do that. Because we have this degeneration, you get on the fundoscopic exam, you get these bone spicule deposits over here. And if you'll notice, this is on the periphery, right? Here we have the optic disc and then the macula and whatnot, but it's on the periphery where we're losing most of the things. Eventually, it will progress to get the cones, but initially just the rods. Pretty much the opposite of this, age-related macular degeneration. Remember that the macula is central vision. Now, usually this is not going to be due to an infarction because of the dual blood supply, the PCA and the MCA. But just as people get older, it's age-related. It's the biggest risk factor. You get this natural buildup of drusen, which is like a cellular debris, fats, proteins that are going to leak out of the vessels and build up. And they're going to ask this. It builds up between the retinal pigment epithelium and Bruch's membrane, which again are sandwiched in between the retina and the choroid, which has the vasculature. This can also just lead to edema if we're pushing too much stuff out. The osmotic pull might pull fluid out. And this is one of 3 ways that we can cause retinal detachment, the exudative mechanism. So loss of central vision is sometimes it's mentioned as a scotoma. And there's 2 types: dry, which is 80%. This is just we have a buildup of drusen, and then wet, which is 20%. Here we can see all of these little, drusen over here. And here in the center, you can see that we have a little bit of macular edema. And so here we're losing our vision in the center, and also notice that we're losing the color as well. And that's because the central vision with the macula fovea is the cone. So you lose central vision, but you also lose the color there as well. So wet versus dry. Dry is just this buildup of drusen. Again, here's our retina, here's our choroid layer, here's our RPE, and here's Bruch's membrane. And it's going to build up between Bruch's membrane and the retinal pigment epithelial cells. This can progress to wet if there is extra VEGF and we have abnormal growth of blood vessels. This can cause hemorrhage and edema, and this is a little bit more of a medical emergency here. We have hemorrhage and more severe edema in this case. Diabetic retinopathy, so similar to like dry versus wet. For AMD, we're also going to have a dry versus wet for diabetic retinopathy. A couple things to look for is we're going to have these aneurysms. Aneurysms lead to hemorrhages. We're going to have ischemia. This is infarction of nerves. We get these cotton wool spots. And if you have the worst type, there's non-proliferative, which is kind of like dry, and then proliferative, which is kind of like wet. You're going to have this abnormal growth of blood vessels. Hard exudates because kind of like drusen, we're pushing out like cellular debris, fats, proteins, and whatnot. So diabetes in general is a silent killer, and this is no exception for the diabetic retinopathy. It might progress for 15 or 20 years before some even knows that they have a symptom. So people are asymptomatic for a long time, and so we can diagnose this based on pathological findings. So the pathophysiology, the progression of this is that hyperglycemia is going to damage pericytes. Pericytes take up too much glucose. Aldose reductase converts this into sorbitol. Sorbitol is very osmotically active. It's going to pull a lot of water in. It's going to kill these pericytes. You can only detect this under a microscope. So, if someone has, early stage diabetes, they've had it for 5 or 6 years, they come in, you actually, in a fundoscopic exam, you probably won't see anything, right? Because it's difficult. You'd have to take a biopsy and look at the pericytes, which is quite difficult. So no clinical presentation at this stage. But over time, we're going to damage these pericytes. Advanced glycation end products are going to stick into the vessels and damage them and maybe cause atherosclerosis. And so we're over time going to weaken the vessel walls, which is going to increase the permeability and the susceptibility to aneurysms. And it's also going to cause unregulated blood flow as we damage these like precapillary sphincters, which is pericytes are helping regulate the blood flow. So All of this leads to, as we said, weakened walls, which leads to aneurysms. Proteins and lipids are now going to leak out of these extra permeable capillaries. And this can be trapped in the retinal tissue. So we see this hard exudate like the drusen. These are the white flecks that we see. Fluid leaking out can lead to edema. And specifically, if it leaks out of the macula, this is actually the main cause of blindness in people with diabetic retinopathy, is damage to the macula via the edema. And as we mentioned, this is a loss of central vision, a scotoma. Unregulated blood flow can, if we don't get enough blood flow to the nerves, can cause an infarct. Nerves are always extra susceptible because they don't have any glycogen, and they just have such high energy demand. So this is known as a cotton wool spot. And we kind of see this here. And the aneurysms, we can kind of see, maybe you can't see it in this picture, but the aneurysms, you can see a little bit under. Do we have any here? Yeah, here's an aneurysm. The aneurysms actually look very similar to the hemorrhages, and one follows the other, so it kind of makes sense that they do. So we have these cotton wool spots, we have these aneurysms, we have the hemorrhages, and then we have the drusen, all pathological findings. But the vascular proliferation, remember, this is the analogous to the wet macular degeneration. This is a compensatory mechanism where we don't have enough blood flow, so our body's thinking, hey, well, we should just grow extra blood vessels. But this is actually bad. These blood vessels are abnormal, and they don't really get the job done, and they can lead to tractional retinal detachment. This is the second of our 3 causes of retinal detachment. This is proliferative retinopathy when we have this vascular proliferation, and this is a medical emergency. So here we can see these, extra growth of blood vessels. This is probably a little bit more severe than it would normally look. Really what you get, and they'll describe this as tortuous. They're all twisted up on themselves. And it kind of reminds me of when I fly home to Florida and I'm looking over at, all our swamps and marshes and the Everglades and whatnot. And these blood vessels kind of look like the tortuous blood vessels during proliferative diabetic retinopathy, which is, again, medical emergency, late stages. More generally, we're going to see these hard exudates, the proteins and the lipids being pushed out of the leaky capillaries. We can see microaneurysms. Notice they say microaneurysm or hemorrhage. They're really hard to tell, but you just see the little red dots. And the hard exudates, which I guess we talked about. And here we can see a little bit of these tortuous blood vessels. Here we go. Here we have a cotton wool spot, which is a nerve infarct. Hypertensive retinopathy, very, very, very similar to non-proliferative diabetic retinopathy. The two differences is difference number 1 is we have AV nicking, and difference number 2 is we have papilledema. So what is AV nicking? So this is arteriovenous crossing. So here we have an artery. Remember, these are more translucent, a little bit smaller, and it's running on top of our vein right there. But because it's normal artery, it just kind of lightly pushes on the vein, and the vein is fine. But in the second picture, in B here we're going to have hypertension. So here I'm going to have an artery, and you can actually see it's a little more thick and a little bit more full, and that's because there's more blood in it, there's more pressure. And so when it moves over our vein, moving up here, notice it compresses the vein, and we get this kind of like hourglass. So the vein is very thick here, and then it kind of like goes in a little bit, goes in, and then it goes out again. So you get this kind of like hourglass shape where you're compressing the vein. And that makes sense. Veins are a little bit more pliable, and arteries are less pliable. And especially if your artery is filled with too much fluid, too much pressure, it can push down and cause this appearance. And papilledema is just, if you have hypertension, elevated intracranial pressure, this can cause papilledema, which is the blurred margins of your optic disc where you have an enlarged blind spot. And really, let's just underscore the major differences. This is our normal optic nerve. Here we're going to have our cup. Here we're going to have our disc. In glaucoma, we have too much intraocular pressure, and that causes this cupping, where the radius of the cup becomes too large relative to the radius of the overall disc. So this central circular bright spot is going to enlarge. So intraocular pressure, this is narrow open angle, too much fluid produced, trabecular meshwork resistance, or you have the pupil dilation causes narrow angle closure. And papilledema, intracranial pressure is up. So this is the opposite here. Tumors, brain bleeds, hydrocephalus, bunch of different causes. And the entire optic disc, it swells on the one hand, kind of looks like the Eye of Sauron, but it blurs. The margins become blurry is I think, for me, easier to see. But there's no retinal cells here, so if you have an enlarged optic disc, we're going to have a larger blind spot. Retinal detachment. So we've talked about 2 out of the 3 ways retinal detachment can happen. This is exactly what it sounds like. The retina is going to peel off. So, here's our retina. It's attached, and it's peeling off. And there's a couple different ways we can happen. One of them involves a retinal tear. That's the third way, which we'll get to in a bit. But imagine if the retina is being peeled off. Well, you're probably stimulating the retina if there's enough force to peel it off. And so stimulation of the retina causes these little flashes. So I would know that photopsia, seeing little flashes, might be a precursor to retinal detachment. So here's our retinal layer, and here's the RPE, and here's the Bruch's membrane, and here's the choroid. If you separate the retina from the choroid, there's no supply of nutrients. So this is a medical emergency. These cells are going to die very quickly if you have a retinal detachment. Here's normal vision. And if the retina is, like folding in on itself, you can literally actually see this is the retina folding over itself like a piece of paper. And so people describe it as it looks like the curtains being drawn over the vision. This is the retina. And this might be completely dark, folding downwards. What are all these little spots, these little floaters and whatnot? Well, if you pull the retina down, a bunch of, cellular debris and crap is going to probably litter the eye. And so that's just going to be picked up. It's going to cast these shadows on the functional retina that still exists, causing all of these little blots. A big risk factor for retinal detachment is myopia. And why myopia? Well, myopia, one of the risk factors for that, the risk factor is that we might, you could have a high refractive index, but maybe you have an elongated eye in the anterior posterior axis. And so here, let's say that this is our retina right here. That's a normal retina. But let's say that if you have a long eye, it's not necessarily that you have more retina. You have the same amount of retinal tissue, but it now has to be stretched because your eye is so long. And if you stretch this retina, you make it thinner and it's more susceptible to tears. Which leads us to our 3 things. So tractional retinal detachment. So proliferative diabetic retinopathy is this neovascularization is actually going to form a little scar tissue. And the vitreous humor over here is going to pull on the scar tissue. It's going to pull it inwards for whatever reason. I don't know why. And it might pull the retina apart. Exudative is the buildup of drusen that we have and macular degeneration. Is going to be osmotic. It's going to pull in fluid, or maybe there's just trauma and more fluids getting in the subretinal layer for whatever reason. All of this fluid in the subretinal layer can just push it outwards. And so that's exudative. And then the third one is regmatogenesis retinal detachment. This is the most common mechanism, and we'll go into more detail talking about this now. So for whatever reason, I don't know why, your body just gets old and shitty, just entropy. The vitreous humor starts to break down. Lysosomes start to release their contents, and it just, there's liquefaction of the vitreous humor. And that forms these little pockets where, the vitreous humor should be jelly-like, but now it's kind of more liquidy. And this is going to cause shifts in pressure. Things are going to move around if you just now have these little pockets of liquid. And things are going to move around. And it might ultimately start pulling the vitreous humor away from the retina over there. And we can kind of see this here. So the vitreous humor is being liquefied, and that causes all of these weird pressure pockets, and it starts tugging where the vitreous humor is attached to the retina. And some of the retinal tissue might float away over here like this. If we tug too hard, it might actually detach the entire vitreous from the retina. So if we look just more at this first case, the vitreous being tugged at and little parts of it breaking off, we call these floaters. We see these little floaters over here, and that's, again, just them casting shadows on the actual functional retina. And so the same way that a TIA, angina might tell you that you're about to have a heart attack. TIA that might tell you you're about to have a big stroke. And if you see a lot of floaters or photopsia, that's telling you that the vitreous humor or the retina is being damaged in some way, and maybe a retinal detachment is incoming, and so you can prepare. And all right, so just to follow the whole thing, liquefaction can lead to little pockets, which leads to vitreous tugging and detachment from the retina. Anytime you're tugging at the retina, this can cause stuff to break off. You get floaters. Pulling at the retina can stimulate it, causing little light flashes, photopsia. And this plugging at the retina can cause a retinal tear. If you have a retinal tear, fluid can rush in. And similar to what we saw with the exudative, a buildup of fluid under the retina. So you can actually see this picture here. Buildup of fluid in here can actually push at the retina, so that the fluid rushing in the subretinal area pushes the retina out, and that is what causes the detachment. And this is going to be even more photopsia, and this is now where we have the curtain coming down. Retinoblastoma, R for retina, B for bone. We have this normal red reflex when we take a picture, the light comes in and it bounces off the eye. That's normal. But if you've got a big tumor, the light comes in and it bounces off. It just has a different, refractive index or different, chromophores, or I'm not even sure why, but maybe it's just the tumor itself. It's just this color. You lose the red reflex, something called leukocoria, leuco-white. So you get this white reflex, and this is a retinoblastoma. Retinal artery occlusion, remember that off the carotid. We have a small little ophthalmic artery which leads to the retinal artery, and what could cause a thrombus or to form, I guess atherosclerosis. That's going to be the big risk factor here. But you could also have an embolus coming from the heart if you have atrial fibrillation, or maybe you have like infective endocarditis, or you have a PFO. So that way a deep vein thrombosis can actually cross from the right atrium to the left atrium and make its way up to the brain. And what you get is this cherry red spot. So notice that you also get this with Tay-Sachs or Niemann-Pick's, which are lysosomal storage diseases. Those, you're going to see that in kids though. So this will be in adults. If you have occlusion downstream or upstream, that means we're going to have ischemia here and here and here. For whatever reason, ischemia causes this little cherry red spot in ways that I don't understand. What's easier to understand though is that we get this particularly pale retina, which is always associated with ischemia. Retinal vein occlusion, so opposite end, here's our retinal vein. This could be from atherosclerosis, causing AV nicking, right? The hypertensive retinopathy, the too much blood in the arteries can compress the veins, causing this little hourglass look. So it doesn't necessarily have to be a clot, but if you have obstruction of outflow, too much is going to build up and it's going to push out, and this can cause edema or hemorrhage. So that's if you have it in a smaller retinal vein. If you have it in a larger, like the central retinal vein, this is probably because you have some like hypercoagulable state. You've got someone who's like a Leiden mutation, or they're on oral contraceptive pills, or they have cancer. And so this is a thrombus disorder. And here we're going to have a much larger hemorrhage, maybe hemorrhages in many different locations. All right, and that is all for eyes. On to the ears. Last section, let's do it. Okay, so sound comes in, you get all these pressure waves. It goes through your outer ear, middle ear, goes these ossicle bones. It's going to cause fluid to go through the cochlea. That gets picked up by cranial nerve 8, the vestibular cochlear. This goes to the medial longitudinal medial geniculate nucleus, which goes to the inferior colliculi, which then goes to the auditory cortex in the temporal region. Typically, though, it's going to go contralaterally, though. So the right ear will go to the left side of the brain for processing. So again, we have our outer ear here. Your ear is an auricle, also known as the pinna. We're then going to go through the external auditory canal. We have the tympanic membrane. Now we're in the inner ear. In the inner ear, we have these 3 auditory muscles, the malleus, the incus, and the stapes. They are going to rhythmically contract. They're going to push on this oval window of the cochlea. That's going to cause fluid to move through this snail-like structure of the cochlea, and it's going to be exciting hair cells that goes through. This is the inner ear here in blue, also known as the labyrinth, because it does kind of look like a maze, right? It looks really complicated, right? Thinking of like the Minotaur of Greek mythology and Theseus. So yeah, it will be hearing and balance. We'll talk about both of them. Hearing first. So sound waves come in. They're going to pump, move all of this. This is going to push on this window here, and then it's going to cause fluid to oscillate through. So we have perilymph and endolymph, and I think they're both moving. I'm a little fuzzy on that, but it's going to move through, and it's going to stimulate this organ of Corti, which sits on the basilar membrane. This has hair cells, which are just going to sort of respond, to the changes in current of the fluid of the endolymph. I would note though for the middle ear that the stapedius cranial nerve 7 is going to help regulate the stapes, and so if you have a Bell's palsy or probably just a Bell's palsy, maybe a stroke, and you don't have innervation here, then you're going to get hyperacusis. Things are going to seem really loud that really aren't that loud. All right, so this is an ugly slide. There's way too much going on here, but whether you want to, I would know that the base is the beginning of the cochlea, the apex is the end. And at the beginning, we respond to high frequency sounds. At the end, we respond to low frequency sounds. We kind of see the same thing here, is that low frequency sounds reach the end, high frequency sounds stimulate the beginning. Fluid is moving through here in the endolymph, and here we have the perilymph on either side of it. And you can just think of, okay, all of these people are hair cells, the organum cordae, the basal membrane, and this is the endolymph responding to fluid, and boom, it's going to stimulate all of these things. All right, so hearing loss can be conductive. The nerve impulse just isn't working. This, for the most part, means that we have an inner ear issue. And it can also be, it can be sensory neural, is everything I just said. Conductive is going to be the opposite. Conductive is that there's like a blockage, there's an obstruction. That's going to be the outer ear or the middle ear. So conductive, blocking, outer, inner, sensory neural, nerve, it's going to be the inner ear. Presbycusis. So Presbyterian, this is elders, this is old people, so natural age-related hearing loss. You can lose your hearing more quickly if you go to loud concerts and listen to loud noises, or construction worker. This is going to, accelerate the presbycusis. Typically, people are going to lose higher frequency hearing first. So I had a physics professor and teacher in high school. He was also the wrestling coach, and I wrestled. So, we'd always mess with him. And he worked as a construction worker when he was younger, and he was old. He had terrible hearing, especially his higher frequency. So in the middle of class, we'd sit at the back, and we would just go beep. We'd just make really high frequency sounds to see if he could hear it. And a lot of times he could hear it. He'd get pissed. Notice that if you listen to really loud noises as well, that this can also bust the tympanic membrane, which is, this is all sensory neural, but busting the tympanic membrane is going to be obstructive. An acoustic, so lots of tumors we could have. Probably the main one is going to be the acoustic neuroma associated with neurofibromatosis type 2 on chromosome 22. And this is just going to press on the sensory neural, the vestibulocochlear nerve. It's going to have maybe a lot of similar symptoms that we would have if we had like a Wallenberg syndrome. Speaking of which, Wallenberg is going to be, maybe it could also be an ACA symptoms as well. Depends how big the tumor is and where exactly it is. But so AICA is going to be the lateral pons. And remember, rule of 4 is cranial nerve 8 is supposed to be in the lateral pons, but it's kind of tricky. It's also a little bit in the medulla as well. It's kind of like, it's got a foot in both camps. Interestingly, if you had 100 AICA strokes, this is going to affect hearing more often than if, let's just make up a number. 80 of the 100 AICA strokes will affect hearing. However, the much more common PICA stroke, the Wallenberg stroke, this is now a little bit inferior, the lateral medullary. If you had 100 strokes, maybe now this is going to be like 40 of those will have hearing issues. But keep in mind that the peak of the Wallenberg stroke is more common than the AICA stroke. So I don't know. I would just look out for it in both of these. Both of them theoretically could cause sensory neural hearing loss. Earwax, this is just going to be obstructive. You got too much wax in, sound has a hard time getting through. Drugs, especially cisplatin, this is ototoxicity. This is going to damage the cranial nerve 8, so this is sensory neural hearing loss. If you go swimming, you get fluid that collects in your ear, and that's just a breeding ground, like a little petri dish for bacteria and viruses to proliferate and cause an infection. Or if you just have an upper respiratory tract infection, there's this eustachian tube that connects the upper respiratory tract with the ear canal. And so you could have an infection travel up through here and get to your ear. So that actually happened for me in the last few days. I had like a cough like a week and a half ago, and then it went to my ear, and it was terrible. If you do swim, you can take ear drops, which are really just isopropyl alcohol. So how does this work? There's a lot of hydrogen bonding, which keeps fluid together. So if you get fluid in your ear, water has like a pretty high boiling point, so it doesn't vaporize that easily. So it's going to stay in your ear. Again, this is a breeding ground, a spawning ground for bacteria and viruses. Isopropyl alcohol, though, doesn't hydrogen bond as well as water does. For one, it's because per atomic mass, per number of atoms, there's not as much opportunity for hydrogen bonding, right? And this OH has 1 oxygen, 2 hydrogens. Each of them could hydrogen bond with something. This isopropyl alcohol just has one OH. So you could maybe have one with the oxygen, one with the hydrogen. You have to keep in mind as well that carbons are electron pushing. So this is partially negative. So this partial negative is going to maybe destabilize the hydrogen bonding. We also have to think about the fact that hydrogen bonds are directional. So they have to have a 180-degree angle. You can't have like 150, 120-degree angle. For all of these reasons, it doesn't really matter. Alcohol evaporates more easily. It's going to interfere with hydrogen bonding. So if you have fluid in your ear after you swim, you put an isopropyl alcohol, it helps evaporate all of that fluid so it leaves your ear so that there's less opportunity for bacteria and viruses to proliferate. Infections could go either way. So again, upper respiratory tract and swimming leads to infections. Now, are they sensory neural? Are they conductive? They can do both. So if you have an inner ear infection, fluid can build up here, and this is otitis media. It could also be otis externa if it's in the ear canal over here. What about over here on this side? If we have an infection of the inner ear, you do not call this otitis interna. You call this labyrinthitis. It's also called vestibular neuritis, and it can affect hearing and it can affect the vestibular system. Kids often stick things in their ears. This can be an obstructive hearing loss. Adults as well. Earrings, especially older people with hearing aids, can get lost in the ears. We got a cool guy outside. All right. You could, people are trying to clean their ears. They can perforate their eardrum. Loud noises also can perforate an eardrum. Trauma. Okay, trauma, obviously, if you get smacked in the ear, and, I did a lot of wrestling, people get cauliflower ear. This can just damage, directly, physically, the external ear and the middle ear. And, but it could also, depending on how hard you get smacked, it could also damage the inner ear and the cause sensory neural hearing loss. So it actually could be either. It seems like it would just be conductive. It is both. All right, a little summary. Presbycusis, you're going to lose your hearing as you get older. Typically, this is going to be the higher frequency sounds first. This is sensory neural. Tumors, tumors are probably going to press the cranial nerve 8. That is going to be sensory neural. Strokes are probably going to be, you get your pica, aeca, your Wallenberg strokes. This is going to be more the damaging of the sensory neural. Conductive, you stick a fire truck in your ear, you got too much earwax, or you're trying to clean your ears and you poke your eardrum. Trauma could be both. Genetics could be both. Probably a little bit more sensory neural, and then infections could definitely be both, right? We have otitis externa, otitis media. It can move through the eustachian tube if you have an upper respiratory tract infection, but then it could also cause labyrinthitis and disturb the cochlea and the vestibular system. So how do we tell whether you have sensory neural or conductive hearing loss? There's the Weber test, and so here we're going to put a tuning fork on the top of your head, and can you tell us Weber, the right side or the left side is louder? So we're going to play this, see which one is louder, left or right side. And then we have the Rennie test, and I think, so remember the auricle of the ear, the outer ear is called the pinna, I think the pinny. And so it's the Rennie under the pinny is how I remember. First, we ring it. Notice that this is outside the ear. So this is going to be testing air conduction. And then we're literally going to press it to, the mastoid process or somewhere in the temporal bone. And the sound's going to move through the bone to get to the inner ear. And so this is bone conduction. So you do the Weber test first. And here we're just seeing, probably someone that realistically we know if there's a problem, and we also know which ear it is because someone comes in and they go, hey, my left ear can't work, or both my ears don't work. But in this theoretical NBME scenario, this is how it's going to happen. We don't know if there's a problem. We don't know maybe which ear there is. So maybe you have an elderly patient, right, where there's an issue with communication. So we do the tuning fork, the Weber test. Can you tell us if this side is louder or if this side is louder? If both sides are equally loud, you're fine. Or technically you could be screwed if both sides are equally quiet, but we'll just assume you're fine. If one side is louder than another, that's going to be the scenario. That's where there's an issue. Now we know something's wrong, but we do not know if it's sensory neural or conductive, and that's confusing, and it's really important to understand. Let's say that this side is louder. Actually, no, let's say this side is quieter. That could mean that there's sensory neural loss. So just like the nerves here aren't working as well. So it doesn't matter if sound's coming from the outside, and it doesn't matter if sound's moving through here. The issue is that we have a damage to the nerve there. That's why this person's left ear will be quieter. So sensory neural loss makes sense. It would be quieter. The kind of more confusing one is that it could actually be that this side is louder and this side is quieter. It actually could be that the louder ear is the one where we have the hearing issue. It could be conductive hearing loss. Imagine that you just got a bunch of earwax, or you got a fire truck stuck in this guy's ear. A lot of the air tries to come in from the outside. It just can't get through the external ear, and can't to be processed by the cochlea and the sensory neural system. So that's why this person's not hearing out of the left ear. But when we do the tuning fork, it's going through here, moving through the bone, and it's bypassing the external in the middle ear, and it's hitting the sensory neural. Okay, well, you might think, well, okay, they could hear then, but like wouldn't be, why would it be louder? And it's because you always have sound coming in through your ears, and if several people are talking at once, the louder person might kind of like muffle the other person. And so this ear is completely quiet. It's a complete vacuum. So there's no sound competing with the sound coming from here. And so this makes it, because there's no background noise, this makes the sound like tunneling through your bones much louder, because going in this ear, it has to compete with all of this outside stuff, and here there's nothing, and so it's going to sound much louder. Now that we know there's a problem, we want to know if it's conductive or sensory neural. This one's a little easier to understand. Air conduction should always be more effective than bone conduction, right? I mean, we evolved to have sounds moving through the air, not through like vibrations of our skull. So normal, the air conduction so first we're going to play it once right here, and then we're going to touch it, Rennie under the pinny. So this is the Rennie test, and it's right under the pin of the auricle, and it's supposed to be bone conduction. It bypasses the external and middle ear and just goes right to the cochlea and the vestibulocochlear nerve. So normally this should be loud, this should be quiet. So that's normal. If we have a sensory neural defect, well, yeah, your sensory, your cranial nerve 8 doesn't work that well, but it still should pick up on the air from the outside more than it picks up in the bone from the inside. Because the issue is not getting through the outer ear and the middle ear. The issue is the nerve itself. So it's gonna be quieter both ways, but again, the air conduction should be louder. Now, if we have a conductive hearing loss, again, the issue is that like there's a clot here. So we just can't get the sound through in this case, because again, there's this large obstruction. But if I have this large obstruction, I'm bypassing that, and I'm just going straight to the source of the cranial nerve 8 in the cochlea, and it's going to be processed, and so the bone conduction will be louder than the air conduction if you had like earwax or something. So taking these two tests together, we can then diagnose somebody. If you are healthy, it should be equal on both sides, and air conduction is better than bone conduction. Now, if it's conductive, it's unequal, and we'll figure out whether it's the quieter or louder ear that's the affected one in a second. Conductive, we have too much earwax. The bone conduction is better than the air conduction because you can't get through from the air, but you can get through if we push it to your temporal bone. And in that case, if it's conductive, that tells us then that the louder ear when we did the Weber test was louder only because there is no background noise competing, and so that the sound becomes amplified. So we can later find out whether the louder or quieter one was the pathologic ear. Sensory neural, again, should be unequal, and if we should have the air conduction greater than the bone conduction, because it's not the issue of getting in, it's the issue of being processed. So getting in is not an issue, so air conduction is still better than bone conduction. And later then we can figure out, okay, when we did the Weber test, it was the quieter ear that's the affected one. Vestibular system. All right, so we have the cochlea over here for hearing, and the vestibular system now is for balance, vertigo, and whatnot. So here are semicircular canals. We have these enlarged ampulla at the bottom here. Then we have the otolith organs, the utricle and the saccule. And so the semicircular canals, we have these 3 little canals going in all of these different, the X, Y, and Z plane. And so if someone shakes their head, yes, like this, back and forth, that's going to stimulate fluid to move through this semicircular canal, which is, they're sensing the acceleration here and the rotational motion. And that's how you can tell when you're nodding your head. You can like feel it. It's physiological, right? And then if you're, I touch my head to my left shoulder, and now I'm touching my head to my right shoulder. The head's moving in this particular direction. And now we're stimulating this semicircular canal. And here we're shaking your head, no, I don't want to take my NBME. Now when we're shaking our head, fluid is moving through here, stimulating hair cells, which are going to cause action potentials, which go to the cerebellum in the brain to let you know where you are, what you're doing. So a lot of this is going to be connected to the eyes. So as we're moving the head left to right, the information from these semicircular canals is going to contribute to the vestibulo-ocular reflex, very much like the lateral gaze reflex, where the FEF goes to the PPRF and the MLF and whatnot. But notice that as this person turns her head, she's keeping her gaze. I screwed it up. She's keeping her gaze completely central. I shouldn't have drawn on it, but you can see what I mean. She's keeping her gaze completely central regardless. And you can do that right now. Look straight ahead. Keep looking straight ahead. Pick an object. I'm looking at some bananas on the table, and I'm rotating my head to the right, and I'm still looking at the bananas. It's kind of amazing that this reflex is just automatic. You don't really have to think about this. Input from the semicircular canals allows this to happen. I don't think you necessarily need to know the whole pathway here, but you should know it works very similar to what we saw earlier with the, when you have a lesion, you have the internuclear ophthalmoplegia. This is very similar to that. Okay, so again, we have these, X, Y, and Z dimensions. We have the ampulla, and it's as we're rotating our head or spinning or something that we're going to have like the endolymph in here flowing, and it's going to stimulate these hair cells, which is going to, let us know that we're moving our head and help with balance and the, vestibulo-ocular reflex and whatnot. So away from the semicircular canals, we're now looking at the otolith organs, which are the utricle and the saccule. The utricle is for horizontal movements, and the saccule is for vertical movements. These are mostly picking up on acceleration. So if you're accelerating like this guy, Brad Pitt, in the horizontal direction, this is going to be the utricle. We have these little calcium carbonate stones, these otoconia, and they're just sitting on top of this. And if you accelerate forwards, this is going to move forwards, and these hair cells are going to pick up on that movement and send messages letting you know that you're accelerating. It doesn't just do acceleration. That would also just tell you this is not acceleration, but if you just, here we're upright and the otoconia are just sitting like that. And here we have our head tilted forward. If you just tilt your head forward, and you close your eyes, you can still know, the proprioception, you can just tell that your head's tilted forward because the otoconia gravity is kind of bringing them down a little bit, and that's bending the hair cells, sending signals. And it's kind of like these little, I forget what these are called. Ghost bubble. It's a ghost device. This is a little like bubble balancing device. It's similar to this with the otoconia shifting to the left or to the right to let you know if you're in balance. All right, vertigo. So vertigo is when we have a mismatch between vision, proprioception, and vestibular systems. These are our big three for balance and just feeling normal, honestly. So vertigo is you have a sensation of the room is spinning even if you're not moving. You might also have nausea and vomiting. So vision, proprioception, and the vestibular system all are going to the inputs to the cerebellum. The cerebellum is the nucleus, which is integrating all of these things and making sense of it. The proprioception from the dorsal column, the medial lemniscus, specifically goes to the vermis in the center, which is the spinocerebellum. And the vestibular system and the vision go to the vestibular cerebellum down here, which is the flocculus, also known as the flocculonodular lobe. Remember that the peripheries are for I want to do a penalty kick, let's do a planned coordinated action. So that's not as involved. So there's two types. We have central versus peripheral vertigo. Peripheral is mostly going to be in the stuff with the ear, and central is going to be a little bit more pressing. It's going to be like you have an issue with your brain. So this is going to be the vestibular system is not working. We have benign paroxysmal positional vertigo, Meniere's disease, vestibular neuritis, and all of these are going to present with either a horizontal nystagmus or a torsional nystagmus. So here's our horizontal nystagmus. You can just kind of see the saccades as the eyes are going to quickly jerk left, right, left, right, left, right. And here are more complex, kind of like up, down, left, right, like diagonal movement is this rotary nystagmus. So this is going to be peripheral. And it's usually positional, not Meniere's, which we'll get to. So that means if you lean my head back, that's going to induce the vertigo. Auditory is usually affected because the vestibular system is right next to the cochlear system. The exception is BPPV. Central now is brainstem or cerebellum, like lesions or tumors or whatnot. So we could have an ischemic stroke. The cerebellum, obviously integrating these three inputs is going to be important. The SCA, AICA, and PCA are all going to cerebellum, cerebellum, and cerebellum. The lateral pontine could be the AAICA. Remember, this is a little bit more sound, but the more common one is the pica. And I remember the medullary in Wallenberg, just so you know that name. This could also be an issue. It's cranial nerve 8, despite the rule of 4s, is kind of in both territories. Multiple sclerosis could demyelinate something, causing a central vertigo. And you could get a vertical nystagmus where you have these kind of like up-down saccades. I couldn't find as many GIFs of that. Auditory is usually not affected unless there's like a brainstem stroke. And again, AICA, despite PICA being more common, AICA is going to be more common for like an auditory issue. Wallenberg will affect the vestibular system a bit more though. And it's usually not positional because it just has to do with the tumor, not like the vestibular system directly. So causes, so we can get these vestibular migraines, which we actually didn't really talk about, but a migraine can actually affect the vestibular system and induce vertigo. BPPV is the most common one, though. I would definitely know that. So when in doubt, BPPV is your best guess. So speaking of which, I mean, it's all in the name. This is benign. It's not like immediately pressing, right? I mean, it's bad, it's concerning, but it's not like you have a tumor and you're going to die. Paroxysmal, it's kind of touch and go. It's hard to predict exactly when it's going to come on. And then positional positions make it worse, and you have vertigo. So the otoconia from the otolith organs, like the utricle and the saccule, they actually dislodge and make their way into either the ampulla or somewhere in the semicircular canal. And we see it right here. And so as you move your head around, nod left, right, up, down, touch your shoulders with your head, this can move the stone around, stimulating the hair cells and blocking flow. And again, you can see this rotary nystagmus. Again, vertical is going to be for the central. And it's very, very positional because as you move around, you're going to move the stone. So the Dix-Hallpike maneuver can diagnose it. So you're just going to take a patient back and then sort of lean them back at this nice 45-degree angle, hold them there, and then the vertigo should be induced. To get the stone out, we have something called the Epley maneuver. So we take someone, we lay him down at a 45-degree angle, wait for 90 seconds or whatever. Turn over to another 45 degrees angle on the other side, and then you're going to rotate their whole body, though, is staying still, but now you're rotating the entire body 90 degrees. And that should get the evil demon, the sucker, out of the semicircular canal with those movements. So vestibular neuritis, also known as labyrinthitis, remember this is an inner ear inflammation, usually following an infection or during an infection. It's typically self-resolving, and it could be positional, but because it's the inner ear, the labyrinth, it's probably going to affect the hearing and the cochlea as well. Meniere's disease is excess endolymph, and remember that big ugly side we had the wave pool. We saw that there's a lot of endolymph that is moving in the cochlea in response to the ossicles banging against the oval window. And that, the movement of that is going to stimulate the basilar membrane and the organ of Corti. So if we have too much endolymph, is too much the endolymph in both the semicircular canals and the cochlea, and this fluid buildup can cause vestibular and auditory symptoms. So it should make sense that it's both. It could be hearing loss, or it could be kind of the opposite. It could be tinnitus, you're hearing ringing, and then vertigo. Again, too much endolymph in both of them. See how this is swollen and this is less swollen. It's not positional because it's just you always have too much endolymph, regardless of which way your head is sitting. So it's just creating too much pressure, which causes all the effects. A diuretic is going to, you're going to have less fluid, means less generation of this endolymph, and it can cause the levels to go back down, hopefully. So moving from peripheral to central could be a tumor, could be causing your central vertigo. Probably an acoustic neuroma or something. Strokes, we said the AICA and the PICA. We should be familiar with all of the symptoms at this point. Romberg. So the Romberg test is going to diagnose this. Well, actually, it's more going to diagnose proprioception, which we'll get to. So as we said, here's our body posture. Here's us not having, body posture is good. No truncal ataxia. We don't have vertigo. This is the proprioception, one, the vestibular, and then the vision. All three of these are integrated in the cerebellum. And when we have all of this working well, our body posture is fine. If you imagine that I take away the cerebellum, well, what's going to happen? If you just think of the physics of this is going to fall over. What if I took away one of these legs? If I take away one of these legs and now I just have this one and this one, it still might be enough to counterbalance this large cerebellum. And counterbalance maybe isn't the best analogy, but that's just the one I found online. But if you would take away two, now it is probably going to fall. So the point is, you take away the cerebellum, you're going to fall. And you take away two of these. We have 1, 2, 3. You take away two of them, then you're going to fall. You just need 2 out of 3 to be fine. So again, vertigo, the mismatch between the sensory inputs between all of these 3 systems. You just need 2 out of 3 to be normal. So the Romberg test. First, we're going to ask you to just stand there. And if you are, excess swaying or loss of balance, even when your eyes are open, then we're going to say that you have a cerebellar issue. Is your cerebellum isn't working, your eyes were open and you fell. It's probably going to be the fact that the problem is that you just can't integrate these things properly. Now, when your eyes close, then you have balance issues. That is said to be a positive Romberg's. And if you close your eyes, you're taking out vision. So what do you got left? You got proprioception here, and you got the vestibular system here. So for the most part, this is used to diagnose proprioceptive dorsal column medium meniscus things, right? Maybe you have like tabes dorsalis, tertiary syphilis, and you don't have proper inputs to the to the spinocerebellum of your brain. This is going to cause an ataxia. So this is to diagnose proprioception. I don't know why that this is not as much used to diagnose vestibular, because as far as I'm thinking, if you close your eyes again, you have this one and this one. If you have a defect in the vestibular system, you should also fall over as well. And maybe it is sometimes, maybe it's the fact that the most common vestibular system is BPPV, which is, as the name implies, positional. And so if you're just standing, you're actually not triggering the vertigo in this way. So the vestibular system is intact if you're just standing there, as opposed to like you're bending your head over. That could be one answer. Maybe there's other things that I'm just not aware of, but I would definitely know the Romberg. So eyes open and you fall, cerebellar issue. Eyes closed and you fall over, either a proprioceptive issue or a vestibular issue because your eyes have been taken out of the equation, but for whatever reason, it is more diagnostic towards the proprioception. Okay, cool. That is it. Thanks everybody for watching. I hope y'all kick ass this upcoming week. Hope everyone's doing well. All the best.